I think
Can
Dr.
you
Jivekar
put
has
that
also
on
come.
the Facebook? Oh, you're controlling from there. Okay. Huh?
Timeline refresh.
This one? This one? Okay, we are live.
Jivekar has also come.
The Facebook? Oh, you're controlling from there.
Here.
What?
Edit.
Edit post?
Edit line. Edit post.
What should I do?
No. Click the three dots. Edit live video.
Then?
Then you get the comments. That's all.
Oh, that's all. Okay.
Click the play. You click
Okay. Sorry.
I started.
Okay, so we are live now on Facebook. We are being joined by a lot of people. We'll wait for another 3-4 minutes and get started. So welcome Dr. Kumar Gaurav. And I'm just going to welcome all the people who are joining. We have with us a very, very eminent otologist. I'm the odd man out. I'm the foreign body here. I call myself foreign body. Yeah, I am actually a rhinologist, actually going to talk about otology. But I wanted to do this because because I have been doing this kind of surgery for a long time now. And what are that? I wanted to actually introspect myself at this stage. Of course, this is not the stage, but at least the postgraduates can introspect and ask for themselves what to choose, because many people in the medical colleges, they are being taught a particular method. For example, if you study in Madras Medical College under Professor Anthony, I think he's also here. So he does a lot of endoscopic stapedectomy. So the postgraduates will go home saying only I'll do endoscopic stapedectomy. And people who are with maybe Dr. Jivekar, Minesh, they'll be trained in microscopic. And of course, if you are with Dr. Professor Murthy Garu, he will train you in almost all the techniques.
No, not like that. I'm doing the both.
You're doing endoscopic and microscopic. So let us now get started.
Nowadays, endoscopic previously I used to do under microscope only, but nowadays I'm doing with endoscope also.
Okay, right. Now, let us get started without much ado. So the program is going to be like this, my dear friends. Welcome Dr. Arun from Madurai, Dr. Sanjeev Kumar Thakur, Abdul Aziz from Pakistan, and we are being joined by a lot of people. We have a huge crowd already, and let us get started. Now, what is the agenda going to be? So we have 3 varieties of surgeons here. We're going to have going to show you a video on post-oral stapedectomy, and Dr. Jivekar, I don't know if he's going to show a video, but we're going to definitely talk every step. And Professor Murthy Garu is also going to talk about, he's going to dissect every step and see what best can be done. Let's go to the video, sir. Can we go to the video? Or first of all, let Dr. Minesh talk a few words, and Professor Minesh and Professor Murthy Garu will talk a few words, and then we'll start.
Thank you.
Professor Minesh.
Yeah, thank you for calling.
Before you start, I want to tell you, sir, I want to introduce you. Of course, you don't need any introduction, but I just want to say one of the best otologists in this part of the world, and I have seen him personally operate, and as well as seen his videos and being praised by one of the dons of otology, Professor Robert Vincent. He is a fantastic otologist, otoneurologist, and the finesse. The most important. I always very obsessed about the finesse of surgery, and that is, God has gifted him with a lot of that finesse, and I'm sure that you're going to enjoy whatever he says today. And he's going to actually examine me and give some marks also. And let's see. So the next moderator is going to be Professor Murthy Garu. And Professor Murthy Garu, I think you have heard him the other day on speaking on pituitary surgery. He is a fantastic all-rounder anterior skull-based surgeon. With respect to the medical college, he's actually in Kakinada Medical College, and he's the professor and head of department. And he does a lot of work. If you go to Kakinada Medical College, you will not find space to even stand. It's so crowded. And he is a teacher of teachers. He sent a lot of his students who are brilliant, actually. I really respect him for a lot of good work which he's doing. So now, first we'll start with Professor Minesh. Over to you, Professor Minesh. Something about stapedectomy. Let's not talk theory. We're just going to talk only practical aspects of what we do. So
Before I
get started.
start, thank you, Janakiram, for the great introduction. And I have a small suggestion since it's there, if it's possible. Now, since we spoke about, I mean, you're yourself a great otologist. People who don't know, I have to tell that, you know, Dr. Janakiram is a great otologist, but somehow he, I think, doesn't focus on it because he wants someone like me to get some name and fame in otology. I think that is one of the reasons he's a very kind person, and I thank him for that. Now, we spoke about, you know, achieving finesse in stapes surgery. You know, it's a very, very interesting thing. Now, I don't know honestly how much time we have. Okay, but
There's no time limit, sir. If they won't, let them leave. We will just discuss, and the postgraduates will stay.
Yeah, because I have a small presentation. Only it's like a small PPT, but it's only on achieving the finesse in stapes surgery.
Perfect.
Now, of course, it's more on my other laptop, so I would have to shift there and come back again. But before we start that, I would just like to tell you, you know, once this word finesse in stapes, according to me, Dr. Janki, is so important. It's so important. The reason I tell you, I just a personal experience. When we used to do a stapes surgery, it was very, very primitive in my medical college times. Now, even a 30 decibel or 35 decibel airborne gap after stapes surgery, most patients used to say, fine, it's fine. You know, you do achieve a reasonably good result. And then when we go all over the world, you see Professor Vincent and you see everybody, they talk about such fine things about a stapes surgery when it comes to the exact length of the piston, the exact measurement of the piston, how the piston should be attached on the incus, the dimensions of the piston. And all these things actually still make that 0.5, 0.75 decibel increment in your final outcome. So before we get into this discussion, which is going to be great, I'm sure, all I want to tell the junior especially is that, you know, the technique is not important. Okay? If you can do the technique and you can get a brilliant result, the result is very, very important. That's most important. See, so it's not really right to say endoscopic is not good or post-oral is not good or endometrial is great. But if you're doing something and getting a good result after all, that's the main thing that actually matters. Now, what I can request is, you know, maybe Dr. Murthy can take over for some time. By the time, maybe I can just shift over to the other laptop and then maybe just present 5 minutes a little about the finesse. So maybe that will be a good idea. Is that okay?
Perfect. Let's ask Professor Murthy Garu to start talking about stapes surgery and his experience on stapes surgery and how you know, it's the king of surgeries. I can call a king of ENT surgeries because we are operating on millimeter. I don't think any other surgery will find its place to replace stapes surgery. Let us go and you know, hand over the mic to Professor Murthy Garu.
Yeah, thank you very much, Dr. Janakiram sir. Actually, you're telling that you're only a rhinologist because I personally conducted one workshop with you from Grommet to Glomus. You remember, I think, probably.
Yeah.
People are spellbound. We did everything, including starting from the Grommet to Glomus jugular. So that was an extraordinary, fantastic workshop that I have conducted. So no arguments over that. You're an all-rounder, everything. Coming to stapes, I really feel it is the most delicate, most magical surgery in ENT. One who can really do an excellent stapedotomy is the real ENT surgeon, I feel, really. Because it needs a lot of experience, a lot of understanding of the middle ear, a lot of understanding of the middle level of the middle ear and all. So it is not like any other surgery. Like any other surgery. It is the most magical surgery. And second thing, you'll be measuring, as you are telling, in millimeters, 0.3, 0.1, 0.2, like that. So it is the most delicate. You require very stable and skilled hands. And you require a good mind to understand the pathology, to understand the structures there. So I feel that it requires a good training. Without a training, you'll be doing more damage to the patient than the benefit. So what I feel as a postgraduates are there, you should practice this on the cadavers once again, many a time. And you should, what I advise was juniors also, when you're doing your first stapes, always keep someone else, your senior, who is very well versed with you or who is a good friendly with you, or ask them to be in your theater. So definitely can learn. That way you can definitely avoid some mistakes also. See, most of the time, suppose you started your practice, you meet the next day, you may get a stapes case, but you're not so confident because your experience is very limited. But around in the post-graduation, you may be given a chance to see or just at least to handle it once or twice. That's all. So this situation, cannot ask the patient to go away, and at the same time, you cannot do it confidently. The solution is to invite someone a senior who has been already doing the surgeries and keep them aside in your theater and then do the surgery under his guidance. So if you do few cases like that, naturally, definitely will help you a lot. So this is my opinion regarding stapedectomy, sir.
Perfect. I fully agree. You should always try to give the best to the patient. And also, this is a surgery which you will give instant result. And you can actually spoil the ear or you can give the complete hearing. So, so let us get started with the presentation of Dr. Minesh, and then we'll go to the video, which I have. The video, every step will be discussed. So the surgery will be completely discussed step by step. Before that, I think if Dr. Minesh is ready with this presentation, we can go to it. Dr. Minesh,
Yeah, I think
are you
he's
ready?
Yes, I think he's ready, sir.
Yeah.
Can you hear me now?
Actually, I'm sorry I didn't inform Dr. Minesh and Dr. Murthy about their videos. I just said please moderate because our agenda was different. But last moment I thought if we have 3 different surgeries, then we can actually have a very good discussion. I'm sorry for putting this forward in the last moment, Dr. Murthy and also Dr. Minesh ji. If you're ready. Okay, before that, I think Dr. Minesh.
I think he's just preparing, sir.
No, his internet connection is a problem. Okay, yeah. He started screen sharing. Dr. Minesh, over to you.
Yes. Can you see my screen right now?
I can't hear you, boss.
Moment, sir. Okay. Is that better? Can you see me? Can you see the screen?
No, we can't hear you. We can see the screen. We can't hear you. Increase your volume, boss. Hello?
Is that better now?
Now it's
Yeah,
fine.
fine.
Yeah,
Yes,
please.
fine. Yeah.
Yeah.
Yeah, it's like a last minute thing. Okay.
I know. I told the audience also that you have not informed.
No, that's fine. That's fine. It's last surprises are always good in life, Dr. Janakiram. So anyway, so I'm just going to very brush through this. Okay, very quickly. 1 minute. Sorry, because my presentation was just ready. Now we spoke about, if you can, yeah. I hope you can see it now. Is it okay?
Yeah, very well, very well.
Okay, just 2 minutes. I'm not going to take much time because this is Dr. Janakiram's presentation.
Take your time.
Sir,
No
please
problem.
take
This is an
time.
informal meeting, and there is
Want
no.
to hear to you.
No, thank you so much. But of course, stapes is something now. What Dr. Murthy said was so correct. I have to share with you, I have a series of stapes surgeries now, more than 798 or something like this, the last numbers which I saw. You will not believe, or people still don't believe, for the first 50 to 75 stapes surgeries, I either had my father or someone else standing behind me.
Yes, that's what I wanted.
It is, and I'll share a very wonderful experience in the last IOW conference which we had. I was doing a stapes surgery. I didn't even know. And then behind me, I saw a figure standing and telling me, correct, go ahead. And I saw behind it was Dr. Mohan Kameshwaran.
Wow.
So all these are things is that, this is such a surgery which you have only one chance. That's the biggest problem. So Dr. Vincent's thing is that you hardly get a second chance in a stapes surgery.
Now
coming back to the thing now, when we are talking about finis in stapes surgery, we are talking about 4 things. One is of course a smooth procedure, better hearing results, less complications, and quick recovery. That's how I look at the finis when you are doing a surgery, not how much bleeding there is or how brilliant you are in talking. It has to be an absolutely smooth procedure, like, without any hiccups in it. And the smoothness does not mean it should be smooth only in the operation theater. It has to be smooth till the end time the patient comes to you with a great result. Now, of course, this is something for the juniors. This is not so much for me because I could not edit this video. There was not much time. But of course, we have to understand that how stapes surgery has evolved. It has evolved drastically over a period of time. And now in today's era, lasers and skeeters are actually a part of stapes surgery, which is more or less essential. They are not something which is can be considered as a luxury in today's world. So again, coming back to the main topic about finis. Now, when we're talking about the advantage of stapes surgery and the amount of success rate today, we can have a success rate up to 90% in the best of hands, But there are failures. Even the best stapes surgeon, like Dr. Vincent, who's got more than 8,000 stapes surgery, has a talk on failures in stapes surgery. So he likes to talk about the failures because he's had them. So there is no 100%, but you have to be careful to try to avoid certain amount of complications. And these are the different things in stapes that can be done as of today. Now, of course, I don't know, is this video being seen? I don't know.
I can see the audiogram. Yeah, the video is seen. Yeah, please.
This is how a stapes surgery would look for a junior. Okay, this is very interesting. Just watch this video. I hope it's clear.
Yeah, very clear.
Okay, so this guy is like the first stapes.
Yes.
It's his first stapes surgery. Okay. He is not knowing what to do. Okay, he's like the juniors. This is for the juniors. Okay, and now he decides, okay, I've read, I'm going to go ahead. He tries again, and now we have a senior behind him. Just like what Dr. Murthy said, the senior has pushed him. And now, but does that mean he's done a fantastic stapes surgery? Not really. He feels now he's the best stapes surgeon in the world. And this is what can happen. So sorry to divert from the topic, but that's the way I think about, stapes can go wrong. But again, just a few more fine points which I can put across here, keeping a little bit faster through this. When we talk about finis, we talk about a good preoperative workup, a good surgical technique, good instrumentation, good prosthesis, and a regular follow-up. So these are the 5 things which I think are essential for a smooth stapes surgery and a smooth result. Now, when we talk about instruments, this is the instrument which I just love. This is something which we are developing with my own thing in Bombay also. This is, of course, a suction, the foot suction, which controls the amount of suction you can do whenever you are close to the foot plate. And of course, you have the best of instruments, which we all have them in India. And now I won't go into the details of this, Dr. Janakiram, but there are so many things in stapes surgery which you can do. The type of CT scan you can do, and what are the advantage of a CT scan. These are really, really huge discussions. But we have a little different topic today. So what we are trying to do is, we have to know and understand that when we do a stapes surgery, you have to have a protocol in mind. You have to have some senior with you, around you. You have to have an idea of what complications you can get and do the right amount of investigations. More importantly, you have to explain to the patients, telling them that the failure rate of this surgery can be really bad in case it can go wrong, and it can happen to anybody. And most importantly, you have to really understand that in case you get failures, do not get upset. Everyone gets failures. I have got failures in stapes. So do not get upset if you get failures. They can happen. The technique is not important. How you do it is not important, but it's basically the final result, and what you are experienced is very, very important. So a lot of things, but this is something which I like to do. This is the interposition technique, which I do with, and this is how the vein graft is basically harvested from the arm or the forearm. And as this vein graft is harvested, what we do is the intima of the vein graft is usually facing upwards. So this is something which I like to do, but I'm not saying that the interposition technique is really helpful when it comes to post-operative fistula. It needs a more bit of experience. It needs some more some more technique when it comes to do it. And this is one thing which I really love to do. You told that speaking about incision. So the incision has to be very clear. It has to be a sort of a one-shot incision from about 12 to 6. And
it's important basically to expose the round window, get a good incision, get good exposure. That's where I think this post-oral technique might have a distinct advantage, you know. So getting an exposure is very, very important in this condition. You can have minimal amount of bleeding, but you have to be very careful. You have to be patient in this surgery. I mean, I can't go into the too many details because this is not really only my talk. We have brilliant guys here who are going to talk much more.
No, you carry on, no problem.
Sir, you please carry on, sir.
Yeah, it's a pleasure.
No one is there.
Always.
We want to hear you.
So there is, you mean to say there is no audience at all? Don't tell me. Oh my God.
There are tons of audience.
He said no one is there. I was shocked, you know. I think I must go home.
Not no one. We're all interested to see you. That's all.
Okay. So now coming back to a few things, you know. So the elevation of the flap. Now, of course, it's so important when you elevate the flap because, you know, it's attached to the annulus and the chorda tympani. Okay, stretching the chorda tympani can be really, really detrimental. So we rarely need to cut it. But yes, it can be an exercise when you're trying to do this procedure, when you're talking about the chorda. Now, if you see here, I'm using a blunt instrument. Do not try to use a sharp knife or a curved pick. That actually might injure the chorda more. I'm keeping a gel foam or sometimes even a cotton there, and you have to be very gentle. It's a nerve. So it's a very gentle nerve. And in case, you know, you have actually stretched the chorda, it can be quite a bit problematic thing. You know, it's a very irritating feeling the patient gets many a times. Again, we're talking about removal of the bony annulus. So when talking about the bony annulus, it's so important to have the right curate. Again, instrumentation, direction of the curate is important. Exposure is important. You know, so curate away from the incus. The movement of the curate should be linear action and it should be your wrist. Don't try to use your arm. And then when you use something like this, when you use a sharp curate like this, you can actually see a beautiful result. So I mean, you're seeing the facial nerve, you're seeing the oval window, you're seeing a small blood vessel over there, seeing the incus, you're seeing basically the stapetal tendon, and you're also seeing a beautiful vessel over the tendon as well. Now this can commonly cause bleeding. So,
Dr. Jivekar, please kindly play the video also. Just definitely it will be very helpful for us. You have all the time.
So
Yeah.
okay, sorry.
In fact, you are the only one
No,
speaking
no,
this.
it was just there. It was just Dr. Janakiram's orders. It was just
Yeah,
there.
just show me the video. That's fine.
So if you really see, you know, if you see in this video, you see the blood vessel, and this is the clarity which you must have. No bleeding, very good exposure to really do your surgery. Again, you're seeing, and then whenever there is an overhang, okay, you always have to remove the overhang, and exposure is the key in stapes surgery. So you talk about endoral incision, you talk about endometrial, you talk about endoscopic, you talk about post-oral. Good exposure is the key. So you expose everything well and take your time as you expose. Take your time. I tell all my juniors, you know, don't look at someone on YouTube who's done stapes in 20 minutes. You take your time because you have only one chance to get this stage surgery right. Again, you're talking about the bony annulus. Okay, so this is a small surgery clip which we are having, you know, with a 27-year-old male patient operated. A large bony annulus was present, and this has to be curated. So again, just showing the video. I hope you can see the video. Can you?
Yeah.
Yes.
Yeah. So this is the initial part, as what I mentioned. So we have the vein graft that has been harvested. Then I'm taking the two vertical incisions first, because when you take the vertical incision, you know, it's elevate the U-shaped incision or the horizontal incision is a little bit easier. Plus, take the incision beyond the malleus. Rarely, you know, 1% chance of mallear ankylosis, but 1% chance is present. So go beyond the malleus to basically check how the malleus is while you elevate the flap. Here we are elevating the flap, just as I said. Be very gentle, be flush with the bone. Be flush with the bone. You can scrape the bone, no problem, but don't scrape the flap. And as you go close to the annulus, it's important to change your instrument into a more blunt instrument. So here we are going a little into the middle ear. If you see, I'm using the blunt part of my instrument gradually.
Yes.
And there is the chorda tympani. I'm gradually separating it. I'm gradually stretching it without causing any amount of neuropraxia. Again, then as we go ahead, as we move a little ahead, this is the large bony overhang which I'm talking about. This can be quite frustrating sometimes. People ask me, should I use a drill? I said, you can use a drill, you can use a Gaussian hammer, but you don't really need it. You know, take your time. What would happen? You would just have to maybe curate 20 minutes more, but you have a good fine control. And if you see, you know, after good curating, this is the picture which we get.
Yes.
So take your time, do good amount of curating. After that, gently, I'm dislocating the incudostapedial joint here, which is special curate got from the COS clinic. And be very gentle when you're dislocating the joint. It won't happen in one go. Be very close, and you have to see that the incus moves separately from the stapes. Here, of course, then we have I've just edited this video. We have the skeeter, and then here what we are doing is we are doing a small opening. We are trying to dislocate, of course, the suprastructure first. I always do that. I don't really believe in the reverse piston technique. So first and foremost, we remove the suprastructure gently. So as the suprastructure is being removed, then you go on to the oval window. So here you're seeing the suprastructure gradually. I'm dissecting it and removing it out. So the CAP suprastructure is out. And now we are going gradually and we are opening on to the oval window. So once the oval window is open, okay, 1 second. So this is the opening of the oval window, if you can see that. Okay, once that is done, then we put in the vein graft. So there's a oval window opening scene. We are putting in the vein graft there. And once the vein graft is put, then we would be putting in the piston. Okay, so this is the piston. Once it is put inside, of course, crimping of the piston is very important. How much to crimp the piston is also very, very important. You don't have to have too tight crimping, because that can also be quite bad when it comes to this kind of surgery. Again, we're talking about stapedial tendon. Watch this video, sir. You know, I'm using a radio frequency probe. Okay, so I'm using a radio frequency for the stapedial tendon. So that blood vessel which we saw sometimes can give some troublesome bleeding if it's really big. So in this, for example, we have to, of course, preserve the stapedial muscle, but the tendon which is there, I used a radio frequency before I cut the tendons. If you see that, you can see some waves. I used a radio free. People can use a laser, but you can use anything that you feel it gives a good result. Again, cutting of the tendon is very important. Cut it in one shot. This is again a different videos. In one shot, you can cut it in here. There is, of course, not much bleeding. And then when you're talking about dislocating, the posterior crus is always, you have to dislocate it as close to the foot plate as possible. And you push the suprastructure down towards the promontory. This is very, very important. So if you're talking about dislocation, this is you go a little below the incus. You dislocate it very, very gently. Use a good sharp instrument. You will get a little bit amount of bleeding. That is fine. And as you go a little bit lower, you be very gentle in trying to dislocate the IS joint. So it's very important to be very careful when you're doing this step. Last but not the least, sometimes you can have the posterior crus, which can have vascular osteospongiosis. You might have to cut the posterior crus with a skeeter. The anterior crus might be really, really thin in most cases. The movement and manipulation, very important in stapes surgery, should be sideways, not parallel to the crura. Otherwise, you're going to get a floating foot plate. You might just avulse out the whole foot plate in no time, and that's not really very good. And so finally, if you're talking about there's another video, I think. So finally, as I showed you, have seen the videos, and now you're seeing the more or less another video. So now this I was talking about measuring the prosthesis. So if you see this video, this is from the COS clinic again. You measure the prosthesis so accurately. It's very, very important to measure the right prosthesis. Now, what length you are measuring, like Huttenbrick said, you add 0.5 mm to the length of the piston. The piston should not be inserted more than 0.25 to 0.5 inside the vestibule. So the measurement of the piston is very, very important in a stapes surgery for a good result. And of course, you know why. You have the utricle and then you have the saccule. So you really want to avoid adrenaline. You want to avoid stimulation of that part. And when you open the foot plate, you have to be very, very careful not to do any amount of suction there. So that's very important. And the vein graft is kept over the piston and it's inserted. So if the patient experiences some amount of vertigo, then that's, of course, irritation of the utricle. So that's an important thing. Last but not the least, just the final few points, the insertion of the piston. You can do it anyway. I mean, we have so many people putting in piston in different ways. But what you do, I've got the separate video. You're actually seeing how I'm opening the oval window. No pressure, just a little bit of fluid and just slow drilling there. If you see that, I hope you can. It's visualizable. I hope you can see it well. So there is just slow drilling. There's a give way action. You see the fluid coming out, do not push it in. You're not drilling a mastoid, you're doing a stapes. So you have to be very gentle in what you do. So you put in a vein graft and then of course, wait for some time. And then you have to basically put in the, insert the piston. So as you insert the piston, be careful, you have to be having a piston with the right length. Sometimes you see this, what happens, like the piston is having a little spring-like action. So there it goes inside.
Yes.
So this action is also very, very important. You may or may not see the round window reflex. I don't really see it in all patients because once you know it's in, it's in. Now, how to place the piston? This is a part of the finish. Crimping has to be done at the narrowest part of the long process. That's very important. And the piston should be as perpendicular to the foot plate as possible. That's very important there. So don't have a curved. I've seen some revision stapes where the piston is curved like 45 degrees, like the Leaning Tower of Pisa, and it's a horrible feeling. So it's not the right way. Now, too tight crimping of the piston can be bad. And reabsorption may not be related to the piston, but it's maybe due to foreign body reaction. So we really don't know why it happens. Certain things are beyond our control, but this is the best which we do. Now, again, when it comes to the finish, you're talking about the size of the piston. I've read a lot of articles on this, what size piston we use. So again, we say that a large diameter piston gives better closure, at least at the lower or mid frequencies. A 0.4 piston is used for better crimping because it's softer, it's smaller, so that's most commonly used. 0.5 mm piston gives uniform improvement. That's what the whole literature has said. And the measurement is done from the oval window to the long process, and you add 0.2 mm. Any piston you can use, whatever you want, Teflon, titanium, both work well. Use what gives you the best results. But Teflon, according to me, has stood the test of time. So according to me, that's something which one should really think of. And again, there are different theories on what kind of piston you must use, what is the diameter you should use. It's all fine, but I feel personally 0.4 to 0.5 mm is the ideal one. That gives a really, really good result. And why? Because people have measured the ratio of the round window velocity, people have measured the thickness, people have measured a lot of things. So they realized that 0.4 to 0.5 was the general thing which people are using all over the world right now. So finally, we have to say something for the resident that it's still a rewarding surgery. Good experience, good exposure, choose your patient well. Counseling is very important. You tell the patient the facts of the surgery, what can happen, what cannot happen. You do a CT scan. I have a lot of people who are reluctant to do a CT scan. Why? I mean, a CT scan now tells you much more. So there is no harm in doing a CT scan now. And a preoperative analysis, of course, is very important. In case you feel you cannot handle it, in case you are having something very different, like maybe something like a dehiscent facial nerve or a perilymph, forget not the perilymph, but a stapedial artery, and you feel you might not be able to handle it, don't put your foot into it. Wait to fight another day. Close, no harm. Tell the patient that I can't do it today, we'll do it another day. Call a senior along with it and do it. So monitor patients for complications and regular follow-up. Friends, I'm telling you, all your results of stapes surgery are the best ones which you can get in any ear surgery. You do any ear surgery, stapes can give you the best hearing results you can have after cochlear implants. I have seen stapes patients who have literally gone mad unimaginably after they have started hearing normally. So it is an extremely, extremely good surgery when it comes to giving you the perfect results. I think that's very, very important. So I close my presentation there, and I thank Dr. Janakiram for this great opportunity. And maybe now I'm eager to hear from the other bosses there.
Okay, so will Professor Murthy talk a few words, or we'll go to the video and
You'll go to the video. That's better because
okay, before going to the
Viveka
video,
has already done everything. Okay, just we'll go to the video and we'll discuss that.
Okay, before that, I want to tell a few words about how my otology career shaped up. I want to tell you that I did my DLO, that is Diploma in Otolaryngology, from 92 to 94. And I did my MS from 95 to 98. Because at that time, we didn't have a straight MS. So we had to do our DLO and then we had to do. So I did a 5-year MS, practically like an MCH. So during my DLO, I didn't know what to do. Like I thought I'll do everything. So But what actually attracted me towards otology was Professor K.K. Ramalingam. There is no doubt about it. He was my professor and teacher, and he used to conduct the ISO, as even now he does. And he brought in Professor John J. Shia. And at that time, I was the travel consultant. Means I used to get the delegates into the bus and get them out of the bus. That was my job. Professor KKR used to love me for that. And I did my job properly. But the moment I saw Professor Shia operating, he operated. I don't know if Professor Murthigaru saw that surgery.
Yes, I was
Till
there in
date,
the workshop.
I have not seen any person doing stapes surgery better than him.
Yes.
Because
He's
the
the father of
whole
it.
hall, you see, he used both the hands to put in the piston. He opened the piston with the right hand and he opened the piston with the left hand. With both the hands, he came down and put the piston. The moment he put the piston, the whole hall stood up and there was a standing ovation.
Standing
And
ovation.
that created goosebumps for me. I said, wow, man, this is what I want. And the moment I joined my MS in 95, in fact, I practiced during my 1993 and I did a lot of stapedectomies, but I think I did around 65 wet temporal bones before I touched my first stapedectomy. And my first stapedectomy, I think Professor Gananathan sir was my guru and mentor. He gave me my first stapes in 1995. I remember even today, and it was on September 17th. September 17th, 1995 was my first stapedectomy. And he said, can you do? I said, sir, let me try. And I did it. And the moment I put in the piston, that time, there was only Andhra Scientific Microscope. It's called BEL. There's one
Yes.
company. And
Yes.
in Madras Medical College, that had only one eye. And that eye also had very, very little vision.
Hazy.
So
Hazy.
today you might be talking about, the best of the best microscopes, eyes and this and that. But we operated when we started with one-eyed, half-light, Bell microscope, Andhra Scientific, and very
Yes.
no skeeter, nothing. But believe me, the first stapedectomy, he said, Janakiram, is it your first? This is what he asked me because he was actually amazed seeing the first stapedectomy. Then I thought, okay. Then he gave me, I think till date, that is a record in Madras Medical College. I've done 18 stapedectomies as a MS postgraduate. And I don't know whether
Right.
anybody has done so many. And that all goes to Professor Gananathan sir. I'll fall at your feet for having done that for me. And there started my career. And from then onwards, I started doing stapedectomy once I started my practice in 1998 till date. And at one stage, I was doing 450 stapedectomies per year. So that was the volume we had in our center. And you can imagine, is it available? The page isn't available right now. Check. Please check. The Facebook page isn't available. No, it's not available. Check, please. Okay, so we have done close to around more than, I think, I don't have any particular record of the numbers.
Records.
Check, please. Okay, so we have done close. Okay, so the thing is that we do roughly around 200 to 250 stapedectomies a year. And initially, during my first phase of my career, I started with endomeatal approach. So I started doing endomeatal stapedectomy. This was till 2004. So from 1998 to 2004, I did endomeatal. And that was actually gorgeous. I gave sort of decent results, as Professor Minesh said, around 90% or so. But then I had an instance where somehow I had to do a post-oral. I don't know. I don't remember that. I started doing post-oral. And believe me, I saw, oh my God, what's happening? This is so simple compared to the endomeatal because I basically believe even in endoscopic sinus surgery, I use both the hands. And Kasam keeps telling right-handed surgeon should use his left hand more than his right hand. This has gone into my brain so much that I want to use both the hands during surgery. So I don't want one hand to be fixed. And usually in stapes surgery, either you hold the speculum, maybe,
Yes.
but to me, I think you are actually wasting one big resource, and that is the left hand. So I started doing my post-oral stapedectomies. And believe me, I thought, oh my God, stapes is so simple. What is the big ado about this stapedectomy? I mean, being that time, at least now everybody is doing stapedectomy, but when I started doing, it was a surgery done only by a few. But then
Yes.
once I started, believe me, every resident who has been in Royal Pearl has done a lot of stapedectomies. So I'm sure even Dr. Uday Chanukya, student of Professor Muti Garu, he did several stapedectomies staying in Royal Pearl. Same way, everybody here does stapedectomies, and this is so simple when you do it post-op. Now, what we are going to do here is we are going to now dissect my stapedectomy. Of course, I had the chance of, you all had the chance of viewing Professor Minish Juvikar doing endomeatal stapedectomy.
Excellent.
Of course, endoscopic, Professor Muti Garu will be discussing. Let us go on to screen sharing without much ado. Let's go for screen sharing. What do I do here? Desktop. Okay, now what you're going to see is my technique of stapedectomy, and that's exactly what I'm going to show you. Now, wait. Can you see my screen, please?
Yes.
Okay, now there's a difference between what Professor Minish Juvikar has projected and what I'm going to show you. This is an unedited version. This is an unedited version. You don't have any editing. You're going to see some blood. You're going to see what you do for in a bloody situation and things like that. So it's not going to be the same like you edit and post it, but this is completely an unedited video. And of course, something like doing a live surgery in front of you. Let's see what is the, can you see the screen, Dr. Murthy Garu?
Yes, sir, we can see.
We can see it very well.
Dr. Minish is also there because I have to ask a lot of questions to both of you. Okay, let's get started. Dr. Minish, are you ready?
Of course, we are waiting.
Okay, right. Now let's see what I do. This is, so now I have taken off that word skull-based surgeon. Okay, now this is the audiogram. So basically, I do an audiology, audiometry, and again and again, I've been trained by Professor Mahadevaya, and he used to say the best test for stapedectomy, stapes surgery is the tuning fork test. So
Yes.
I believe that every postgraduate should be able to do a Rennie Weber and a ABC, and that is a very clear message which he gave to me. I have attended several of his workshops, and believe me, Mahadevaya sir is a genius in stapes surgery. He's a class apart. And he always used to say there's nothing, no role of impedance. But of course, I do an impedance as well. And I do a CT scan also for every case of stapes just to see the facial nerve overhang and a few anatomical abnormalities. Okay, having said that, I always operate on the worst ear. And it's always better to operate on the right ear for a right-handed individual. For a right-handed surgeon, to me, I think the right ear is slightly better. So even in an implant, I choose the right ear rather than the left ear. So I'm going to ask if both the panelists agree or they're going to choose the other ear. Left will be better than the right. So Dr. Minish, over to you. What is your choice? The left ear. Both the ears have the same kind of hearing loss. Which ear do you choose?
See, I usually prefer to do the left ear first.
Because I saw all your videos left ear, so I was a little,
Yes.
because what you have shown will be exactly opposite to what I'm going to show. So there are a lot of steps which are going to be totally
Left,
different.
left.
So I'm
The
very
choice
happy
is
that
mine. It's always a left.
your choice is left, is it?
Yes, yes, definitely. Being a right-handed person, I feel better in the left side.
Right-handed person, left side is better. Okay, for me,
Yeah,
the
that's what
right-handed
I
surgeon, the right is better. I don't know why, but I mean, it's a personal choice. Of course, the audience can choose what they want. But to me, I think the right is better for me rather than the left. Okay, fine. So that just the question there. Okay, let's go on, and that's our theater setup. Of course, I'm using the Labomed. Of course, I have the Pentero as well, the microscope. I use that for the skull base, and we have the 4K monitors and the Spice. The Labomed, I think I will strongly recommend to all the juniors. It's a fantastic microscope, believe me. I have been using a lot of this Labomed. We have around 2 in our theater, apart from so many Zeiss. But if you want to perform a good, decent mid-layer work, I think I would cost effectively, I think Labomed will be better. What is your choice of microscope, Professor Murthy Garu, Professor?
Sir, we're having the Zeiss only. I've been using the Zeiss only, sir.
Okay, and what about Professor Minish?
Yeah, I have two microscopes we use. One in my clinic, I use the Zeiss, and in Bombay Hospital, we have the molar Wedel one, which is the neurosurgery microscope.
Okay.
So that's also a fantastic microscope. But the only problem about these neurosurgery microscopes, I realize, is they are very bulky,
Yeah.
huge.
The Pentro is very bulky. We have the Pentro. It's a very
Yes,
bulky one.
yes,
I use
it's
that for
really
the skull base. The only thing which the postgraduate should understand is that you have automatic controls. If you go for bigger ones, you have automatic zoom controls, whereas this is manual. So that is something which I always say. But the light intensity in a labomed is very good. So I'm very happy with the light intensity. You're going to see that anyways. So let's now go on, and that is our theater setup. And now this is the, of course, the right ear. And so the most important question I want to ask Professor Minish first is, what anesthesia do you choose for stapes surgery?
This is something which you're going to kill me now.
Can you increase your volume, Professor Minish, please? Can you increase?
One second. I think I'll listen.
Thoda kam hai.
Is this better? Abhi aa raha hai? Is it better?
That is better. That is better. Thank you so much.
I think you don't need this. Well, I tell you, in the first few 200-300 surgeries which I did, the stapes surgeries, I did it all under local anesthesia, everything. Now, for some reason, in the last maybe 8 years, I have shifted to general anesthesia. Now, this is a controversial topic. Many people would not like it. Many people do it. It's a different thing. But I have 4 aspects to it, which is very important, which I think is important to highlight here. Now, I stay in people where a lot of educated people are here. Now, when you ask a patient about any surgery, any surgery in the world, ask a lady about a delivery, what does the patient or the human being remember the most? They remember the pain. And the pain is a memory in the patient's mind, which he sometimes feels is worse than the hearing. So I feel that some of my patients did have some amount of discomfort, sleeping, some amount of nausea, maybe some amount of discomfort, and they were not too happy with it. And plus, because I take the vein graft, I know I have to give some anesthesia here and plus in the ear. So I do it under general anesthesia, and I'm very happy with it.
Sir, I always do it under local anesthesia only, but we always have an anesthetist in the if they are required. That's my routine job. That's what I do.
Okay, so having an anesthetist is almost a mandatory stuff. There is no option in it. But what are the advantages, for the sake of postgraduates, what are the advantages of local anesthesia? One is that if you have, you want to test the hearing, then I think local is simply out of the world. You can actually, you're going to see in this video how we test the hearing also. Number one.
Yes.
Number two is that if you have a longer piston, you will have giddiness. The patient will say, oh, I have giddiness. So something like if you do test under local, if you touch the lamina or the dura, they will have pain. So the same thing, you have complete control.
Protect it from the complications.
Yeah, you can prevent it from a complication, and that local is fantastic. And what is the solution I use? It's again by Professor Mahadevia. It's called the 10-10-10 solution. I don't know if he uses the 8-8-8. I use the 10-10-10. So what's the 10-10-10? I give a pre-medication of a 4-twin Phenergan, and also I give alprazolam one night before, and also sometimes to the attender also if they are apprehensive. And what is the 10-10-10? 10 cc of 2% xylocate, 10 cc of distilled water with 10 drops of adrenaline. So this is actually the
same thing we're also following.
You're also following the
same thing we follow. Yeah, of course.
Yeah. So what are the points in which we anesthetize? I have a little technique here. In fact, none of my mastoid cases I do it under GA. So the first will be the greater auricular nerve. So I go by the nerve, the greater auricular nerve, and then the lesser occipital nerve here. So the first nerve, the second nerve. So please understand, my dear postgraduates, what are the pain sensitive structures? You should understand why you are giving this anesthesia, because you want to obviate the pain. So skin is pain sensitive. Second is the dura. Dura is pain sensitive. So, or the periosteum is pain sensitive. There are only 3 structures which are pain sensitive. So if you anesthetize all the 3, then the pain is not there. The middle ear, Mahadevia sir recommends a little xylocaine solution, but I don't use that because there is an incidence of SN loss, so I don't use that. So you see here, I start from the greater auricular nerve. I start, and the nerve divides into 2. So I give it right at this point where, both the branches are gone. And then I go for the lesser occipital. and you see that's the second injection, and the third injection will go on to the periosteum. So see here, the first periosteum I inject is right. You see, if I bisect here, then I give one injection here. So that is the exact site in which I give the injection. So please understand, this is going to be very practical, my dear friends. Maybe I might not talk a lot of theory, but theory you can read it in any books. But these are the things you might really get to know. My techniques, like you see here, this is the first site of the periosteum. The second site of the periosteum, you direct your needle around 45 degrees. All these are being taught to my residents. It's like mathematics for us. So 45 degrees, and then you have the periosteum just above the 12 o'clock position, and that is where the needle will be. Right there, that is the periosteum, and then I will inject there. So always try to withdraw your needle, always try to withdraw. And then what I do is what is called the superficial 4-quadrant infiltration. So that is for the auriculotemporal nerve. You see here, what I do is that the first injection, this is very important. Some people see that's auriculotemporal going. And then I put that right underneath the skin. So this is where the patient will have a little pain. So what we do is we apply Prelox ointment. So Prelocaine, so that there is no pain during the injection. See that's just the skin in front of the tragus. So this I call as the superficial 4-quadrant infiltration.
4 points,
So,
yes.
yeah, 4 points. It's just the 3, 12,
3,
6,
6,
and the
12,
9. 6 and the 9. So the superficial is, this is a little, important in stapes surgery. And then what happens is that I go in for what is called the deep quadrant infiltration. There is a little difference between mastectomy and stapedectomy, because in a mastectomy, what I do is I inject a little more in the deep quadrant, so that the local percolates down and comes out through the perforation. So that the whole flap is raised automatically by something like the septal correction. If you inject, you can raise the mucopericardial flap. The same way I can rise the skin beautifully, but here in stapes surgery, don't do that. Because if you do that, what will happen is that you will raise an epithelial bleb. So there will be an epithelial bleb on the layer. Never inject too much in the deep quadrant. This is very important. I always tell my residents, don't inject too much. Inject a little, but see what happens is that's the injection. So where is the site of the deep injection? This is very, very important. Many people I've seen, they do a lot of wrong stuff, because what they do is that's the isthmus. All of you know what is the isthmus, and they go medial to the isthmus. Never go medial to the isthmus for injection. Always inject lateral to the isthmus. So if you inject, so what you do is put your speculum. You can use a slotted or a non-slotted speculum. It depends upon whatever you want. Put that slotted speculum and press it towards the part which you're going to operate. Okay, so that this doesn't percolate laterally. And then you go deep, that is towards the bony bony canal, and then withdraw it a little bit. You withdraw it a little bit, so you have the isthmus. You know the feel of the isthmus, and then inject right there. So you have, see that is the injection. Don't give too much. That is, and when I see people injecting, even if one drop of solution comes out, I know the surgeon doesn't have the plane. So these are the things I always look for. Where is that solution coming out? Is it coming out into the canal? If it comes out into the canal, you have done a wrong step. These are the important, very, very high level finesse. See that is rising a bleb. There is not a drop of solution which is coming out. These are the most important things. Now, the next step is the most important part of the debate, the endoscopic versus the endomeatal of, Professor Juvekar versus our post-oral approach. Now, what are the advantages which I'm going to get? Well, I counsel the patient. See, most of my residents are there, even in London. They are there in UK, everywhere. I mean, in Middle East, everywhere. And whoever has got trained in Royal Pearl, they do it post-oral. And they say, there is no fuss at all, sir. When I convince them, there is no problem. They say, okay, the only thing is the scar. Believe me, it's only the scar. And that scar is completely camouflaged because it's post-oral. You will not, and people think it's an overkill. Believe me, it's not an overkill. So I have been asked many questions. They ask me, is your result good? Is your result better in a post-oral? Believe me, the steps are so simple because you are so used to mastectomy, and you do mastectomy not by an endomeatal incision. You do it by a post-oral incision. And every day you do hundreds of mastectomies a month. So this is almost the same. So, I mean, that is why I chose, and you will see what are the differences when you actually approach a stapes post-orally. Now, I start the incision with a diathermy. I don't use a knife at all in stapes. That's the difference between my incision in stapes versus incision in a mastectomy. In a mastectomy, I use a knife, but in a stapes, I use a let's see now. See that. Now,
advantage, sir? What is the advantage, sir? Janakiram,
yeah,
sir?
see, you cannot even see one RBC. You cannot see even one RBC in this surgery. You just see, it's an unedited video. You just see whether you can see an RBC. People talk about bleeding in post-oral, all that. You cannot see one RBC in a post-oral mastectomy. Let's see whether I'm true or false. See here. Now you see that. I'm now starting. You have two auricularis posterior muscle. So I'm going to, basically see the muscle coming up, very clearly seeing the muscle. Previously, what we used to do is, we have done a paper also on the greater auricular nerve. So we used to do what's called greater auricular nerve transposition. So I think Omkar was doing a paper on that. He is now in Indore. So I used to trace the greater auricular nerve going into the pinna. And I used to completely dissect that and rotate it anteriorly so that he doesn't have any problem with the numbness. Of course, in stapedectomy, you can't do that because you're using diathermy. But if you use a knife, I can trace even the fibrils of the greater auricular nerve. Again, the finesse involved in mastoid surgery. Of course, I have not discussed this because I never demonstrated my ear surgery. Now you see that's auricularis posterior muscle. So you can see that I'm now using diathermy and trying to slice that. I never cut, I slice. It's always a slice. But you see what's happening, my dear friends, my dear postgraduates. Do you think my right hand is working? This is my right hand. The suction is because you have to absorb the fumes from the diathermy. But more importantly, only observe my left hand. Just observe my left hand. The left hand is giving the pull. So the pull itself is going to dissect. So you will get a plane with your left hand. So I always see in a surgeon, a right-handed surgeon, the left-handed surgeon, the right hand. So I always assess my postgraduates like that. I mean, the residents like that. You see here, see my left hand giving the maximum traction there. See that again, the left hand. So once you do that, see that what we do, that's a post-auricular muscle. I'm cutting that. And then I'm coming into the fibroareolar the layer. You can see that. That is the tissue there. And then I will palpate. I'll palpate. And then you see, almost every stapes surgery of us will be just like this. I just want to show you one. I don't have to show you hundreds. It's going to be like this. So we did at least 5 surgeries this week. And all of them, Harsha was seeing, they say it's just the action replay. It's only the difference in foot plate. So you can see that I'm palpating. Every time you use your left hand to palpate. So I've seen people actually incising the canal and putting a buttonhole here. So even my residents, what they do is unknowingly they put I say, oh my God, this is not finesse, man. So you keep the left hand should guide. It's like tracheostomy, palpate. My teachers used to say, palpate the trachea. The same way you palpate with your index finger. See what's happening. I'm just palpating and I'm just going. And you see that? Now again, I'm palpating. This is very important, my dear friends. The left hand, the left finger. Never forget your left finger if you're a good surgeon. This is what Kasam keeps telling. Now, that's actually, if you actually want, some people actually get this very important complication. I've seen people making an incision here and they have a lot of bleeding here. So if you dissect the artery, the posterior auricular artery, I have completely dissected the artery. Right here, it comes here and gives off 2 branches. I can show you in some of my mastectomies, I dissect that artery completely and I can get into all the branches of the posterior auricular artery. So what you have to do is slightly go posterior as you go inferior. So never go anterior as you go inferior. Go slightly posterior because the artery hugs the pinna. The artery hugs the pinna, and you see what happens is that you will not have bleeding if you go slightly posterior. That's the areolar tissue. You see what's the plane? Absolutely brilliant. That's the artery. See that? Now I exactly know, but that's not the main artery. And now I'm just going there, and you can see that I am now putting, you see, did you find the difference? Now my left hand is not being used. Instead of my left hand, what did I use? I used a retractor. So I'm using the retractor to give me the traction. These are the fine points, my dear friends. You see that? I'm now going there and giving that. And very important here, see here. Now, Why did I give this injection? Why did I give this injection in this periosteum? Because I always believe in exposing the ear anterior to the malleus. Please understand, anterior to the malleus. Why? Why anterior to the malleus? We have found in several cases malleus fixation. And if you have a malleus fixation, and if you have not exposed the malleus completely, believe me, you're struck. You're completely struck. I have seen people doing a stapedectomy right from here to here. Maybe from, if it's this right here, it's going to be 11 o'clock to 5 o'clock or 6 o'clock. And that is going to be a help for them, because if you don't expose the malleus properly, then if you have a malleus fixation, of course, a CT will definitely give you but anterior malleolar ligament can be ossified. We have seen that, and there is a completely different technique for that. Okay, I can show you techniques for that. You see here, now you are able to see some RBCs, 1 or 2 RBCs, because I'm using cold steel instruments. And this is where I use my bipolar. I have a bipolar at a setting of 20. And here you can see that Dr. Minesh was giving an incision from inside. But what I do is I give an incision from outside. I train all my residents to give this. And how do I know this is the 6 o'clock or the, is it? So basically, please understand, this is the Henle spine here. And you know the depth of the TM from here, of course, and just make it inferior to the Henle. And I make it exactly at the 7 o'clock position. This is the 7 o'clock position. That's where the skin is the thinnest. You see what I'm using with my left hand? I always tell, use your left hand for retraction of the skin. You see what I'm trying to do now? See here, I'm now making the incision right there. You see my left hand. Don't watch my right hand, watch my left hand. So I'm making that incision. You see how, now you see what I did was my eye is giving a sight of the TM. I exactly know where the TM is. And now once my left hand pushes that flap, I exactly know where to give this incision. So this is what we have been doing in thousands and thousands of mastectomies. Of course, you can see how you can see exactly a sharp. Rosen sometimes is not a very good instrument because it becomes a little blunt after use. But the knife never becomes blunt. It's a sharp, clean cut. You can see that's a cut. And please understand, my dear friends, this cut is not from the 7 o'clock to 11 o'clock. It's right from the 12 o'clock position or maybe the 1 o'clock position till the level of the 6 o'clock position. It should be measured. You cannot just make an incision, improper incision. You should make a complete incision, but the anterior part of the incision should extend till the level of the 1 o'clock position. Because again, I say that if you have a malleus fixation, you are into trouble. So you are ready for anything there. You are ready for any complication. You see how I'm now trying to take that incision anterior to the malleus. You see that's the malleus here. You can see, I don't know if you can see that. That's the malleus. Can you see that, Professor Minesh? Hello?
Yes, I'm following you.
Okay, now it's same like the mastectomy. See, this hardly takes how many minutes? 4 minutes now. In the unedited video, 4 minutes I took for exposing the canal. Maybe you might do it in 1.5 to 2 minutes. Okay, that 2 minutes I've lost in this. I tell you, the time is not a criteria for a good surgeon. This is very important. And then what I do is I put a retractor. See the retractor. Now you see, I can see right till the anterior, annulus. Very beautifully, I can have a complete control of this. If I have an anterior malleus
360 degrees, you have got the control. You have 360 degree control.
Absolute
This is
control.
the
Of course,
entire
it's not a meningoplasty. It's not a meningoplasty, but I am ready to tackle anything here. Whether it's a malleus fixate, whatever it is, I can tackle here with this kind of exposure. So that is my first advantage. And believe me, what happens is that there are some people who have a very big Henle spine. So what I do at this step is I drill off that Henle spine. So with a diamond burr, I drill it off and nicely give irrigation so that the bone dust doesn't go inside. So what happens is that I am like an open book. And sometimes what happens is there is a temporum squamous suture line which is very prominent.
Yes.
And what I do is I drill it off. I drill that suture line with a diamond burr so that I have a complete control on the malleus. So these are the 2 important steps I have not shown in this video, but I do that and I tell my residents to do that as well. Now, very important, what happens is that you have a little bleeding. So the best is irrigation. My dear friends, most important thing is irrigation. The best way, whether it's the nose, it's the larynx, whatever, best way to prevent bleeding is irrigation. Irrigation. Even in the brain, it is irrigation. So when you irrigate, bleeding stops. So this is a very, and of course, In the nose, we have warm saline, but in the ear, we have just normal saline at normal temperature. And see here, there's a difference. Dr. Minay showed me that he puts an incision vertically. There is a 1 horizontal incision and 2 vertical incisions. But I don't do that. I was doing it during my postgraduate early days. But what I do is I make an incision like that. It's not horizontal, it's not a vertical, but I make it oblique incision. So what happens is that, why do I make an oblique 2 incisions is because I can extend the tympanomeatal flap anteriorly if I want. But if I make that vertical cut, I can't extend that anteriorly. Number one, this is the first point for which I make oblique incisions and not vertical incisions. Number two is that there are people who are novice to ear surgery, and when they make that incision, sometimes when you elevate, that vertical incision can tear through it. And there will be, I have seen some people making a little tear on the tympanic membrane. And that is why what I do is you can see the modification of this incision. Of course, all these I have not seen anybody doing it. I'm just doing it out of my experience, not published. Please understand, it's not published. Don't say all this in exams, but this is what I do. You see that it's not a vertical incision, but oblique incision. And then what happens is that I can rise the flap almost beautifully. So see that now. And see my left hand, the finesse in using that left hand is ultimate. Believe me, you can put the suction behind that Rosen's elevator. You see that? I'm seeing an end-on view, absolutely end-on view. And this is around the 5th minute of my surgery. You can see that I'm using the end-on view. I can see every bit of what I'm elevating. This is very important. There is no way I will be causing a tear. Even the thinnest canal wall skin is not a problem. Now, what happens is that at this stage, I look for bleeding. I look for RBCs. If the RBCs are collected, then I wait, I irrigate, or I use bipolar. But if I open the middle ear, then there should not be any blood. This is very important, because if you have blood, then it will go into the middle ear and you'll have to suck that every time. So that's not a great idea to do. And you see what I do is I stop at the level of the annulus. And then what happens is that I use a sharp, I first irrigate very well. Yeah, I get a question from Dr. Siddiq saying that single point at 11 o'clock infiltration is enough, sir. Yeah, I understand your point, Dr. Siddiq, sir. And please understand, there is no one way in doing surgery. You cannot say this is wrong, this is right. Everybody has his own technique. Only thing is that we have not published. Maybe you can publish 11 o'clock alone is enough, or Dr. Minish, or Professor Vincent has published. So we have to accept his views. But then there is no one way in doing surgery. Please understand this. So if I am right, maybe you're right, and Dr. Minish is right, Dr. Murthy is right, everybody is right. Only thing is we should give results to the patient. That is the ultimate goal. You don't have to say that I am an endoscopic surgeon, and so I'm better. It's not so. Being better is only in the results, not in the technique. So basically, I'm just posting my technique to you. And if you feel that it's bad, then I don't mind, because just one other technique, that's it. You're seeing just one other technique. If you want, follow it. That's it. Hi, Dr. Leena. Welcome. See, what I do is I just keep that Rosen's there. I keep my suction. My left hand is very important for me. And what I do now is I use a hook. A very important thing is this is my a very important wand. I call this a magic wand. And I use the hook so often. I don't use a drum elevator. The reason is because to me, I think it might cause a little less finer dissection. So I want to expose the malleus. So basically I go right till the malleus, and I know where the chorda is. So that's very important. I'm just cutting off the mucosa from the TM flap. And then, of course, in this case, I didn't elevate it till the 6 o'clock. Of course, I can go right there. And what I do is I have seen in MMC, they keep a little cotton ball and press that flap there. I also sometimes do that. Sometimes I don't do that. But very important that I expose the malleus. You see how the malleus is exposed here. See the exposure. Please understand, my dear friends, see the exposure. Now I'll stop the video. And then what I will do is I'm going to ask what are the differences which Dr. Murthy sir feels and Dr. Minish sir feels. Over to you, Dr. Minish.
Yes, can you hear me?
Absolutely, I can hear you very well.
Yes, it's very interesting. It's very interesting. What I have seen in this whole thing is, of course, the hand movement. Okay, is very interesting. You are doing it very naturally with using both hands, and I definitely see the advantage which you're having with them. I would also see the advantage in this whole technique when we have an extremely narrow canal, where you sometimes have to go endometrial and then you think you can't do it, then you go post-oral again. So that's a distinct advantage we have. But the most important point, which I thought of your beautiful presentation so far, was that you told everybody that these are different techniques which we are presenting in front of you for the juniors, and your results are the most important thing.
Absolutely.
So the result is the most important thing. How you go to like drive a car is not, the final result is so important. So in these things you are getting a better, definitely we are all used to a mastoid surgery. Definitely we are used to a post-oral approach. So this approach is definitely less cumbersome than the endometrial one. Well, I don't know, but my only limitations is, if you have a young lady for stapes surgery, or sometimes patients are not so keen to have a scar. So my question to you is, suppose we have a patient who tells you that, okay, I would like to do a stapes surgery from Dr. Janakiram, but I don't want a scar behind. Would you still try to convince the patient to do it endometrially, or would you like to refer the patient to Bombay?
Yeah, I would love to refer her to you,
To Jivekar.
because you are also a handsome surgeon. So, but I just want to tell you that I always counsel them for 3 important things before surgery. Number 1 is a hearing aid. I always give the 50-50 option to hearing aid, and I always say there is no failure in a hearing aid. This is a very important statement. I say, if you want to choose your surgery, despite the fact that you know that you're going to have 5% failure, then come to me. This is the first statement I make to every stapes patient. The second important statement I make is that I have done, so I can switch over to endometrial, whatever I can just, suppose I have had pilots who said, I want to endometrial. Yes, I have got trained in endometrial as well. So that's not an issue at all. I can do even endoscopic. So, but the important point here is to show to the audience that there is a technique like this, because many people would be shy and refrain from showing. They might say, oh, what the hell, man, he's doing a post-oral stapedectomy for, stapes surgery for just a small endometrial. But believe me, there's a lot of advantage. If the lady comes, she's insisting on that, I tell her one more point. I tell her, very important point, my results in endometrial surgery would be around 88 to 92%. But my results in a post-oral surgery might be 92 to 95%. 5% chance that they can have failure. Why? Because I will tell you, the next few steps are the most important steps, which will actually determine, and I'm going to ask you the next few steps, what you will do in an endometrial approach. This is why I put this catch case for you. And we are waiting. It's just the start. So we're going to have a hot debate. Now, let's see what Professor Murthy Garu says.
Sir, as you said, it's a very familiar way for all of us, doing every day in and out the mastoids and all. Fine. Second thing here, both are really free. Even if you're doing an endometrial, even if you have the speculum or whatever it may be, still your hands are not free. Both hands are not free. So now we are able to operate better with both your hands. Third point is, as you said, the space is good. You got more space instruments. See, when you're doing endometrial, you always put your instrument straight from your eye. That's all. So sometimes you'll also get your instruments in the way of your looking through the microscope. So all these things can be avoided here. But I was not trained in this way. That's why I'm not doing this. But as Jivekar says, it's finding interesting also. Let us go further, sir.
Okay, I'm just asking you one question before we go further. If you're saying it's better, why don't you do it?
Yes, I'll start doing it. Maybe from tomorrow I'll start doing it. If it's looking nice, I'll do it.
I'm not preaching a technique, please understand.
No, not like that. As you said, see, we are seeing everything. I have seen the Jivekars and I'm seeing you.
Yeah.
We'll try.
Okay, let's see what is the advantage. The real advantage starts here. The real advantage starts here.
Sir, as you said, there are only 2 routes to reach the goal or foot plate. Is it not? As endometrial or the post-oral, the 2 different routes to reach the goal. Yeah. So, okay, let us see further.
No, everything, actually the final goal is more important. How you reach it.
That's what I'm saying.
The more important is the goal. If you're having very good results in your endometrial, please carry on. Please carry on and do that technique. Okay, fine. Let's now go on. And the most important thing is exposing that malleus. And that is very important. I want to see the malleus because I can deal with any malleus fixation
Yes.
here. So
Yes,
that's very important. And
definitely.
then, see, I'm going to tell you something which I have been doing for the past 10 years or maybe even 12 years now. I don't use a curette. So this is something very different from what Professor Juvekar has shown you. Why? Why don't I use a curette? To me, I always believe in movements which start from point A to point B. If you determine a movement, a curette, you give a pressure at one point and you don't know at what pressure you're going to stop that movement. So this is very important. Imagine you're going to curette. So I've seen even some people overshooting with a curette. They just overshoot. And this is very important when you actually talk about an incus dislocation. This is, I have seen postgraduates, my own residents, when they use the curette, they will either tear the skin of the posterior canal or they will overshoot. And I always say in surgery, you cannot overshoot. You should have measured movements. And that is why I'm going to ask you, see here. Now you see
Means
here.
the control over the current is very less, you mean to say.
Absolute control. I have,
Yes.
you don't have a control on curettes. Curette, if
Yes.
you have a very sharp curette, you have controls.
Of
Of course,
course.
doctor, don't compare yours. My curette with Professor Vinish curette. He's got the world-class cost curette,
Instruments for him.
but I don't
course.
have them. So I have a Jesco or maybe a Stores curette, but after some time it becomes a little blunt.
Naturally.
It becomes a little blunt. So what happens is that I have started using, see what I do. So I use a combination of burr. You see what I try to do? I'm using the burr, but see what I'm trying to do is I'm trying to drill lateral. Very, very important. I drill lateral and leave. See that? I irrigate like a fanatic. I irrigate so much that there is no bone dust collected at all. So the question of bone dust absolutely doesn't arise because I keep on irrigating. You see, it's around 30 seconds of irrigation. But what you have observed here is that that thick bone has been drilled out and I left behind a thin shell of bone. This is very, very, very important. See what I did. I didn't completely drill it right till the level of the incus. What I did was I drilled it and then I left behind. And so what happens is the curette has got a complete control now. Now, when I curette it, see what happens. Now I have a complete control. And now I'm going to take my curette. This is an unedited video, please. So now I have the control and just one small, even that, you see the point B was wrong. If I look at the point B, it was wrong. See, now it's point B is correct. So point A to point B, you can see that how much of control you need when you are doing a stapes surgery. This is, to me, the finesse of surgery. So you have to have an absolute control of your point A, and then where is your point B? See here, when you do the curette, did you observe that? I always tell my residents, never see the tip of the curette. People who are, mediocre surgeons, they see the tip of the curette. Who are good surgeons above the stem. See the stem. Where is the stem? It's applying pressure on this canal. So imagine that you're going to apply pressure on the canal. So you should be conscious about the stem. You will cause a little hematoma here. And I've seen it'll be like a war field. Many stapes surgeries, there'll be a war field here on the external canal, and there'll be a lot of hematomas bleeding from the external canal. But here, then what you should do is you keep exactly in the center. The curette should not rest on the canal. This is very important. Look at the stem, not at the tip. My dear friends, it's very important in surgery that the whole instrument is under control. And you see what Dr. Juvekar said, a very important point I want to convey here. I saw Professor Juvekar, actually what he did was he pushed the chorda to at the level of its origin. To me, I think I would never do that because at the level of the origin, it is running in a canal. There is a chorda canal there, and if you try to force it here, then what happens is there is a more shearing. Then this end of the chorda is more free. So I always tell my residents, try to push the chorda at the level of the malleus and not at the level of the chorda canal. So what I do is I uncap the canal. You see how I uncap the canal? You see that So see, I'm now pushing it at the level of the malleus, and then what happens is that I'm now trying to drill a little bit lateral, never go towards the cauda at all, because you don't want to damage the cauda. If you damage the cauda and cut the cauda, I think you're not a great stapes surgeon. That's for sure for me. And what I do is I thin out the cauda canal. In every case, I thin out the canal, and then I write completely copiously irrigated. And if you observe the cauda canal is a bony canal. It has got a lateral aspect and has a medial aspect. So when you want to see that cauda now, that's a canal here, that's a canal. It has got a medial and a lateral. Now I'm curating the lateral aspect of the canal. See the lateral aspect of the canal, the cauda canal is being drilled out, curated out, and then I will push the cauda and I will now drill the medial aspect of the canal. So this is, I feel, see that is the medial aspect of the canal. Now the cauda gets completely released. Now the cauda is completely, but if you, without doing this step, try to manipulate on the cauda, there's every chance that you might shear it or cut it, or it might even get damaged. So this is very important to actually curate the cauda canal. That's very important. So sometimes you might not have a big canal, you might have a small canal, and for that, what you can do is just uncap that bone lateral to the cauda. This is very important. Again, a small step, maybe not of big use, but to me, I think it carries a lot of importance. To me, it's very important. So these are the, I call, not discussed too many times in any conference. How do you uncap a cauda canal? So same way where I uncap the nasolacrimal duct as well. You have an anterior and a posterior wall. The same way the cauda canal has got a lateral and a medial wall. And you see how I'm uncapping both these walls, the lateral wall and the medial wall. And you can see that this is the uncapping of that canal. And once I spend a lot of time, now you see the cauda is completely free. You see, to free the cauda, you don't have to apply a lot of pressure. You just have to uncap this canal. And if you uncap this canal, the cauda
Automatically
becomes
released.
the cauda becomes completely free. So any comments, Professor Minesh? And what's your experience on this?
Well, there are few things which I would point out here. Of course, nothing. What I felt, as a very honest and a very friendly discussion.
Oh yeah, you can dissect it. You can make a sarcastic comment. I am totally open. I am totally open, my dear friend.
No, I'm not.
We are discussing academics.
No, a very serious academic point, not sarcastic at all. That's not.
Yeah, absolutely.
See, what I felt was that's fine. I mean, but I'm not really honestly so convinced of using the drill for this procedure for a few reasons, which I felt so.
Yeah.
Yes, I mean, of course, yes, instruments are fine and things like this. Now, I still feel that bone dust here, okay, you cannot really be sure that there is going to be zero bone dust inside the middle ear after that. There is bound to be some amount of bone dust inside the ear as you do it. That is one. Second, I feel that at any point of time, the heat generated from polishing burr is much higher than that of a cutting burr. I don't really think, of course, if you have a very big bony overhang, like in one video which I saw, you might tend to use the burr in case you're really not really able to do it with the curate. But I think a burr might sometimes remove too much of excessive bone in the posterior superior area if you're not careful in the long run. That is best. Now, when it comes to the cauda, I think yes. I mean, getting the cauda out from the canal and elevating it, it all depends on each position of the IS joint. Sometimes it's just on the cauda, sometimes it's away from the cauda. So an individual case is absolutely different. But in something which I'm seeing now, on a very honest opinion, I realize that I feel that maybe the posterior superior area, you have exposed it beautifully, that's fine. But I think there has been a lot of excessive drilling or excessive exposure in that area, perhaps. Maybe I'm not able to see it very, very clearly. But of course, on a good point, I would also say that for people who are used to a post-oral approach, this is a much more authentic, this is a much more easier way to understand your landmarks and approach the whole stapes problem. That is definitely, I would agree to that. If you are doing something endometrially, maybe you are handling, and of course, if you have a malleolar ankylosis, of course, then you need a drill, and for that, this is, I would say, the perfect procedure where you can go there and try to release the malleus from the fixation. So according to me, it's a good procedure, according to me, yes. But maybe if you're used to the endometrial, you wouldn't really want to use the drill for that, for such reason. I don't know. Dr. Murthy might have a different opinion.
Before
Sir,
that,
sir, that's
before
what
Dr.
exactly.
Murthy,
See, this drilling is possible.
Before Dr. Murthy sir tells, I want to tell something, Professor Minesh
Please.
ji.
Yes.
Please.
In an endometrial, it's almost very difficult to drill. With
Yes,
a
that's
burr.
what I'm telling.
Without
That's
a
what.
skeeter, you cannot drill, and a skeeter can slip. Okay,
Yes.
this is a 2 millimeter burr. It's a 2 millimeter burr or a 2.5 millimeter burr, and you can have a precision only in a post. So this is one reason I chose a post-oral, because I didn't want to use a curette. The curette is, to me, not the instrument of choice. I never use curettes in pituitary. If you're looking at it, I do an extra capsular dissection. It's the same. It's the same. No surgery can be just like that. From an area where you're blind to an area where you can see is not surgery. You have to see the whole the whole field. This is my concept. The heat, as I told you, what is it going to disturb here? The posterior superior canal heat, even if you have, what is it? I'm not going towards the carda at all. The carda can be damaged by the heat. Of an endoscope also, they say the carda can be damaged. That's a different issue. But I'm not going towards any vital structure when I drill there. So to me, the heat concept, to me, I might not be able to accept. Number two is that you said that the bone dust. The bone dust should not go into the vestibule, not into the middle ear. Middle ear can have any amount of bone dust, not a problem at all. You should not cover the round window. You should not go into the vestibule. It should not go into the vestibule. These are the two areas you should be doubly sure that it doesn't go into. This is very, very important. And I believe that when you wash very nicely, to me, I have not had any problems in having a bone dust going there. Of course, microscopic bone dust you can have, but then you cannot use the skeeter at all. If you say like that, then you should not use the skeeter at all, because skeeter also produces a lot of bone dust. So you cannot use the skeeter. You should, I mean, I don't know of any other technique except the perforator. Even perforator, you'll have a little bone dust going there. So I think the
Amount of
the
dust.
argument about the bone dust, I wouldn't agree at all, because then you can't use anything if you have a bone. Yes, Professor Murthy garu, you can carry on.
Sir, as you said, the drilling through endometrial approach is not possible because you will never see the where you're drilling exactly. Unless you open post-circular like this, it's not possible to drill. Secondly, I always use a curette only. I always use a curette only most of times because of I do endometrial. Second thing is the releasing the carda from this bony canal. Most of the times it's not necessary because
Yes.
you have enough space above that. It's okay.
Yes.
But
Fully agree.
few times I also do it. But as you said, I also curate over the bony canal and release it from the canal instead of stretching it too much. That's
Fully
what
agree.
I do. And second thing, as Janakiram sir says, bone drill there. As you said, when there's a very narrow canal, sometimes I drill outside, but not on the postmetal wall or where the just above the chorda tympani. This is what I
so
feel.
I think that's a good argument. I mean, let the audience decide. We are now giving a lot of options to them. No one person is right. Please understand, surgery is like a flower. Each flower is beautiful. Jasmine is beautiful. Rose is beautiful. If Murthy garu is rose, and
Oh my God,
Ganesh is
not at
lotus.
all. You are
then-
everything. You are everything.
Let me at least be a cactus. Let me be a cactus.
You are everything. You are everything.
No,
You're
no.
all combined.
Okay, let us see now. Let us go on to the
Yes.
scientific part. Very important aspect which I want to say is that when you're doing this, always ask your assistant to tilt towards you. This is a very important thing which people
That's
forget.
very important.
Yes, you should tilt towards you, because sometimes what will happen is you keep drilling and you will actually drill more. So if you
Yes.
have an end-on view, then you will exactly have two landmarks. That is, one is the horizontal part of the facial nerve, or the junction of the long process with the body. This is what I always say. And then I will look at the pyramid.
Neck.
So these are the two important landmarks till which you have to drill. Of course, in an endoscopic, I don't know, Professor Murthy garu can say, do you use the same landmarks or do you do less?
Same, sir. Same landmarks. You
Yes.
cannot change them. It's always the same.
Okay, right. So now what happens is that again, irrigation, try to irrigate. No blood should go there. So I'm trying to irrigate. Okay, fine. So please remember, it's an unedited video. So you might find a little. Yeah, okay. So till now, it's around 10 minutes, 45 seconds. Now,
your
what I'm
hands.
trying to do is to remove that small mucosal band from the cauda so that I can have a clear view of the cauda. And now I will tilt the patient. So everything is completely mathematics. Now I've tilted the patient. You can see here very nicely exposure there. That's the incus here, and that's actually the pyramid. And then what I do is, if there is bleeding here, I use adrenaline-soaked gel foam. So this is very important. I always believe in this because this is, to me, a very important magic solution to stop all that RBCs. I don't want to have a lot of bleeding there. And I keep adrenaline gel foam, wait for a long time. I don't mind spending time. But once I wait, it stops. The bleeding stops. And that happens a little towards the cauda and also towards the end of this flap. This flap, also a little bleeding comes. So see that it stopped completely. Now, of course, the next step, I want to tell you that, you see here, now I didn't show you that, I tested the mobility, but the most important thing here is to assess the foot plate. So Dr. Mire showed you the type 1 foot plate. So there are 4 types of foot plate for the sake of postgraduates. You have 4 types of foot plates. Number 1 is the blue mantle. Number 2 is the milky opalescence. Number 3 is the biscuit type. Number 4A is the partially obliterative, and 4B is completely obliterative foot plate. So we have operated on almost all the kinds of foot plate. So what do you think this kind of foot plate is? You have a lot of vascularity, almost no definition of the foot plate. So this is going to be a 4A. So this is going to be a partially obliterative foot plate with a lot of vascularity. This is where your post-oral is going to be like a magic. I'm sure that you're going to fight with this guy if you do it endomeatal. I'm sure. You see, there's a little rotation of the stapes. Usually you don't see this. You see the anterior crust as well as the posterior crust here. But you see the foot plate is completely filled with autosclerotic focus. Now, let us see now what is the advantage. Of course, I use a scissors, but this scissors is a little towards me. I use a bent scissors. Let us pass on. Of course, if it's going to be a thin foot plate, I make the fenestra before I cut the crura. So that's very important. Now you see what I do is I drill off. See the magnification I use to drill the posterior crust. I'm using a skeeter right now. And before, I just want to have a small, see here, always test the skeeter before you go inside. This is very important. Postgraduates, please test the skeeter. There are people who put the skeeter inside without even testing it. Test your revolutions. Test whether there's a wobble in the bar. Everything should be tested. And then what you do is start burring the posterior crust. There is no role for rocking technique. There are some people who rock the stapes. There is no role for rocking technique in my books. So what I do is I completely, this is a type 4A. So you can actually play with the foot plate. It's not going to transmit any, play with the crura. It's not going to transmit any vibrations inside. So I know what kind of foot plate I'm dealing with. And now you see there's a little bled there. And I'm now drilling the anterior crust. Of course, the anterior crust, sometimes I don't even do that. I just rock the anterior crust. And then, very important, when you dislocate the incudostapedial joint, that instrument with Professor Jovica showed was very good. But here, there's one point I want to add. You always have an articular disc here. There's an articular disc. And the articular disc of the incudostapedial joint should be along with the incus. Never, take the articular disc towards the stapes. So you have more, length of the lenticular process. You see that I'm going inferior to the articular disc. It's very important. That's a small point, but then for the sake of postgrad, you see that articular disc is here. See that. You can see even that disc here. You can see the articular disc.
That's seen
very clearly. You always go inferior to the articular disc. Okay, fine. Here, you sometimes when you have the patient had a Schwartz sign positive, you had a lot of blood vessels over the promontory. I could see that reddish tympanic membrane. You will have bleeding, my dear friend. You will have bleeding. And if you have bleeding, what do you do? So I'm going to show you a scenario, not like a perfect type 1 foot plate where you just have no bleeding. Let us see what you do in this situation. So that's the facial now. Foot plate not clearly seen at all. And now what you do, the best way is to keep adrenaline soaked gel foam. So I'm going to place adrenaline soaked gel foam. You see that bleeding? It's because of the vascularity. It's fully vascular. And you can see that what I will do is I will keep that for a long time, and then I will just slowly try to spend my time, and I'm trying to gently score the mucosa. I score the mucosa. In a case of a type 4 foot plate, you don't have a problem of scoring the mucosa. So you score the mucosa with a gel foam, with adrenaline, and then keep that adrenaline again, and then again score the mucosa so that you don't have bleeding. That's very important to control that small arterioles which are present over the foot plate. It's very important. And once you do that, sometimes, and then what you do, I have one technique of stopping this bleeding. I put some little gel foam on that skeeter, and then I drill along with that. So it's like a gel foam pit over that bleeding area. So it stops. So if it's a thick foot plate, don't do that in a thin foot plate. If it's a thick foot plate, what I do is I keep a little gel foam and drill over it. And what happens, you see that, and you see my left hand. It's very important. Can you do this in an endometrial technique? You cannot do that. I'm for sure telling you, you have to stop. You have to wait. But if you have a thick, type 4 foot plate, believe me that this is 14 minutes now. You would have taken more than, time is not the criteria, but it will cause a nuisance, bleeding, and then you stop. It's a pain. Believe me, I get frustrated doing that. Believe me, sir, I'm not trying to, propagate a technique.
You have so many patients waiting for surgery. We hardly have any patients waiting for surgery. So for us, maybe.
No, that's not the point, sir. You see, it's not a question of time, but it's a question of getting frustrated by the bleeding. See, if you have a cavernous sinus bleeding, if you have the other hand, you can just suck and keep doing the tumor. But if you don't have that.
Yeah, can I make a point here?
Yeah.
Yeah. See, what I saw in this surgery right now, what you were doing, okay, the posterior crus, which you were drilling, was having more vascularity, a little more like an osteospongosis.
Yes.
Okay? So the bleeding usually arises when you have the little reddish or the pinkish color foot plate as compared to the pure white suprastructure, as compared to the pure white stapes suprastructure. In these cases, either what I like to do is either before using a skeeter, I either use a laser or sometimes a radio frequency beam just over that crura to sort of make it a little more avascular before I drill it, and this to a large extent also reduces this kind of a bleeding later on. But definitely the one of the crura posteriorly was much more vascular as compared to the anterior one. And of course, adrenaline and everything is okay, but maybe you could also avoid the bleeding. Yes, please go on. Please.
Yeah, that's a good point. Actually, if you have the laser, then it definitely has a lot of advantages. There's no doubt. But I don't think many of the centers might be having the laser. There are very few who can afford the luminous laser. And so I think I'm going to show this as a cold steel procedure. Of course, I can show you some with the laser as well. But now I'm just going to show you how we deal with it if you don't have the laser. That's a good point. Radio frequency or the laser is a great point. But then it's a must in stapes surgery. I don't disagree with you. But then there are some centers which don't have, and if you go and get stuck there, then that is the problem. If you're called to operate in a conference and you don't have a laser there, what do you do? I mean, you're handicapped, totally handicapped. And what do you say to the patient? It's going to be difficult. Now, I think this is a technique where you can definitely follow it in any other conferences.
Basic technique.
Yeah, it's basic. It's the basic technique. But of course, skeeter is definitely needed. But what I mean to say is then, if you don't have the laser, you can definitely see what happens is that I use a little cotton ball. Of course, it's not highly recommended, but then if you have a lot of bleeding, then it's very, very, very difficult to control that bleeding. So I use that, and then I make sure I use it over a gel foam. So I use it over a gel foam, and then I wait for some time, unedited video again. Just want to remind my. So these are the techniques I use. Maybe on for criticism.
Same thing anywhere, sir. Same techniques anywhere usually.
No, some people say you should not use the cotton ball. I agree, but then it doesn't give pressure.
Fibers.
You can use Merocil, a small Merocil, this one, but then you see, I make sure that the.
I don't use I don't use the cotton ball into the middle ear.
Yeah.
I usually use the gel foam only. That will suffice.
Gel foam,
or a small Merocil you can use, sir.
Yeah. If you can use Merocil. You see the autospondiosis, it's actually involving the foot plate. It's a very thick foot plate. And you see what I do
Yeah.
is I use a little gel foam. Can you see my left hand is pushing that gel foam a little?
Yes,
And then I'm drilling.
yes.
See, that is
Yes.
a technique to stop the bleeding. See, that's something like a bone pate. It's a beautiful technique to stop bleeding. In fact, if a type 4A and B, which we operate, this is something which has not been described. I don't know if I'm not very much into the literature of otology, but I don't know if it's been described. It's my own technique. You see here now, see, there's still a little bleeding. Of course, it's very close to the facial nerve. And you see how after drilling it, it almost completely stops.
Yeah.
And now what I'm trying to do is I'm trying to again use my skeeter.
Skitter.
That you see that if you use the cotton ball, again, I want to tell you what is the
Yes, that's
complication
one
of
point.
that.
That's
It
one
actually
thing.
rotates on the burr. That is very important. I'm just showing you everything. So it's not like I'm hiding anything to, you know. So you can see that there is a small, you see that small ledge-like bone. On
Yes,
either side,
yes.
you have the autosclerosis. I don't know if it's clear, Murthy garu,
You
sir.
can see.
Yeah,
You can see, sir.
Now you
you
see,
can see
again,
small.
I'm drilling.
Shining.
This cannot be done with a laser. You have to use a burr or you have to use a perforator. Perforator will take at least some 3-4 hours. If you want to do this with a perforator, believe me, it's going to be.
And the foot plate is so thick, you should have a skater, no doubt in that.
Yeah, so you need definitely a skeeter. And very important that many people I've seen is that they drill like a well. And that's exactly what I don't do.
No.
What I do is I completely tilt
Sausage.
that foot plate. I
Sausage it
completely
in
tilt
fact.
that foot plate. See what I do? I completely saucerize and
Sausage it.
yeah, you see that?
Sausage it, in fact.
I made a complete bay-like technique of the foot plate. And now I've stopped using gel foam because I'm very close in blue lining the foot plate. You can see that. I'm now drilling that. And what I usually do, I always use a combination of skeeter with a perforator, like how I use my burr with a curette. I use a, so I always, when I see the blue, I stop. When I see the blue, I stop.
You
so
stop.
Yeah, I stop. You see what I do that. So whenever I see the blue, I stop. That's just the blue lining,
Yes.
blue lining of the foot plate. So you can see that. See how
The
much
very
of
thick
drilling
foot
is
plate,
required.
yeah. Yes, yes, it's very thick.
It's very thick. It's of type 4A. It's
Yes,
really thick foot
yes.
plate. And I mean, in this case, if you're going to do endometrial, believe me, it's going to be really tough for you. It's not an easy job. It's going to be tough with one hand, and you're going to have bleeding. And I can't even imagine doing that. It's going to be a pain for me. Now let us see. So you can predict it with the CD scan. With the CD scan, you can predict what kind of approach. So this is one additional point I want to convey to the postgraduates. So you can actually, with the type of foot plate, you can actually decide on what approach you do. To me, I think endometrial for this kind, 4B and 4A, is going to be a hell, believe me. For a type 1, it's nothing you can do anyway. But for a 4A, 4B, that's why I was trying to post this case out of all the stapedectomies. I mean, you see here, now it's a big bay, still not got the blue. I've been drilling for at least now 3.5 minutes. 3.5 minutes of drilling and at least 2 minutes of having the gel foam. So much of drilling the bone. Okay, now still not got the blue. So again, for the postgraduates, this bone dust should not go inside. So it's not more important for the bone dust of the canal to go inside. This bone dust from the foot plate should not go inside. Then you will land up with the SN loss. So this is something which is very, very important. Don't, you keep irrigating, now I use the saline soaked gel foam. I never use adrenaline over the foot plate. So I change to saline. So my stuff automatically changes to saline soaked gel foam. And my suction is controllable. We have the Atmos suction. We have power controls. It's, of course, I've seen Manyan using the foot control for the suction, which Professor Juveka was talking about. But I think if you go in for a very high-end suction, you have a completely, when you do brain surgery, you can control the suction power. So that's what we do in stapes surgery as well. So we reduce the power as we go towards the foot plate. It's a very, very less suction power. So you can see that these are the points I want to convey for the postgraduates, of course. The professors here are more well-learned. See how much of drilling, huh?
Oh my God, it's already.
So,
Professor Juvekar, anything to add in this, sir? In such a
anything
thick
to do
foot
different
plate?
in this, Professor Juvekar, sir?
Well, there are other few points is that, one thing which maybe I can add, of course, it's a very well done surgery. There's no question. Approach is not important. What I wish to say is that with this amount of audiometry which you had shown and the longevity of the disease or the hearing loss the patient had, along with a compilation of maybe a good reading of the CT scan, would actually give us a reasonable idea that we might expect this.
Foot plate might be so
Yeah,
thick.
So you have to combine the three things together is very, very
Fully
important.
agree.
And as I said, and as you're doing it rightly, of course, that we need to be very patient in these cases, especially for the juniors. Don't try to open it as if you're opening a mastoid antrum. It might take time. Take your own time, because sometimes if you just maybe pump it and it goes
You
inside.
continue the video, sir. Okay.
I'm sorry. So the most important, as Professor Juvekar says, never give a pressure. Pressure. See the blue line now. You have
Yes,
to get
now we
that
can
blue
see.
line. You see that blue line so beautifully seen. Until that you drill. You never open it
Yes.
accidentally. There's no accidents in surgery. Everything is controlled. Now you see, my suction power is the least here. Now the brain suction. It's like putting the suction very close to the cranial nerve. And then what I do is I keep a little a saline gel foam to take off all that. And then
Use
I
a
irrigate. See,
perforator.
irrigation.
Fine.
Irrigation is very, very, very important. The bone dust should not go inside. This is where you're worried about bone dust. So here is where you're worried about bone dust. Now, having done that, see how even the water is not being sucked by the suction. It's a very, very low power on the suction.
Fine.
You can see the blue line there very clearly. And now what you do is use the perforator now. I use always the perforator. And it's a very sharp perforator by Karl Storz. You can see that now I will be using the perforator. So it's a combination of
Skeeter and perforators.
Yes, I use the skeeter and the perforator once. If it's going to be a type 1, then I straight away use a perforator. If it's going to be a 2, then I again slightly combine it. Now you see what happens is that I go there. And it's a 0.6. I always make a 0.6 fenestra. Okay. So that's it. I've done that to my satisfaction. And then what I do, I don't make that perilymph ooze too much. So I place a little dry gel foam. Dry gel foam. And then, of course, the measuring has been shown beautifully by Professor Juvekar. I'm not going to show you that. I measure that. And this was around 4.5. And then you see, this is the piston I use. It's a Teflon piston. And basically, you see, the hold is very important. There are two important things I want you to notice, my dear friends. I always tell this when I do my sinus surgery or skull-based surgery. Your angle of vision and angle of introduction should be different. It should be at least more than 30 degrees. So this is very important. Why? Because if you have a zero vision, if I have a vision on that and I put my instrument, you will not see the tip. You will not see the tip and so what I do is my vision is from here, from above, and my introduction is from below. See, that's very important. At least 30 degrees should be there. And the first to go in should be the base. And you should see the base and then gently press that against the lenticular process. So this is a very important step. Many people, they confuse. You see where I'm holding the piston. The hold also is very important. I always tell, hold the piston properly. And most of the pistons should go in your first shot. So that's the first shot. And that's it. It's going right there. And you can see that this is putting that. And then I crimp the piston with a piston crimper, of course. And once you do that, so you do it at the, as Professor Juvekar says, at the narrow part of the incus. And once you do that, you don't have to have a bend or something like that. See the depth. You can do the bending test, the hanging test, whatever you want with that. I did that. And then what I do is I take a little soft tissue. This is always what I do. Of course, I learned it from Professor Mahadevia. And I take a little soft tissue. Of course, since I have a postoral scar, of course, if you have an endomyelitis,
you can take it from there.
Yeah, you can take it from the lobule. So here I have so much of soft tissue. If you use a vein, then you don't need
Juvekar sir, what do you use? Fat or any tissue? What do you use?
I usually use it, I take a vein graft. So I use the interposition.
Of course. Yes.
So most of the time I have some of the vein graft left behind in case I want to seal it. But the vein graft is of course all sealed.
Of course, that's always the best. In
Yeah,
case of either fat or the soft tissue, which one do you prefer,
I
sir?
always use fat. Whenever I've used so far, I've always used fat because yes, of course, here he has
Yes.
access to the soft tissue very easily. But then,
Yes,
as
yes.
Dr. Janki said, then the earlobe is the next closest thing which you can.
I always use a fat, sir, because it takes the shape of the where you put it.
It
So
can,
when you
yes.
put it all around, it always takes the shape, and
Yes,
it's very settles very beautifully all around the piston.
One
So
of
I always
the
use a fat only.
one of the advantage which struck me of the post-oral technique is, sometimes when I have seen a couple of, I'm working now in medical college now. So
Sir.
sometimes when some of the juniors are actually doing the surgery, they tear the TM or the flap. So
Okay.
in those cases, if you don't have a vein graft, you need some tissue to repair the tympanic membrane or maybe the flap.
Of course. There also it's useful.
Here,
Simply
of
can
course,
take a small bit of the graft.
fascia and that can also be done.
This is a fibroareolar tissue. This is a fibroareolar tissue. It takes the shape of the, you see how it beautifully takes the shape. In fact, this is far better than the fat. Fat doesn't take the shape like this. It's a fibroareolar tissue. And this is what Professor Mahadevia keeps telling. And you can see that this actually comes and jams beautifully on the anterior and the posterior aspect. I use two. And
Sir, do you require to put so much of the soft tissue around?
No, actually it's magnified. It's very small. Actually, you can see that this is not, I mean, it's a very, very small layer of soft tissue right around.
Sorry.
And then what I do is I use the CADA.
Naturally.
I use the CADA to
course.
actually prevent the piston
Slipping of the
step.
piston. Yes.
So I'm going to show that step. And whenever I always say, reduce your magnification when you put the piston. This is very
Of
important.
course.
Don't put it under high magnification. This is one point I didn't tell when I was making my presentation. So you see, I'm using gel foam on the suction when I do the CADA work. So this is again a little trick. You don't want to suck over the CADA and cause a problem. So you can see the CADA beautifully lying once I decompress the canal. It's so beautiful. And what is the main difference between, at least I don't know, I've never seen this in any workshop, any center. This is what we have been following for the past 20 years. You just see that is definitely different. You're going to see that. This might actually jerk off many people. Just have a look at what we do. Now, this all, I mean, it's all routine. But what we do after this is I do the, of course, the audiogram also has been done by Professor A.B.R. Desai. He does an intra-op audiogram. But what we do is, now I keep a little, I don't fill the ear with gel foam. I just keep over the incision, just over the incision. And then I keep that other skin flap right over it. And then that actually keeps the canal very clean. You can see that again, the left hand, movement of the left hand, very important. The movement of the left hand, see the left hand, how it's helping me on the right hand. So that's it. So that's the end of the surgery per se, but it's still not the end. So what is the advantage of local now? So in all our cases, what we do is, see, there is no guarantee that you will not have SN loss in a later date, maybe years later. Of course, you can sometimes have a loss, even sometimes maybe a month or two, or I don't know, we might have a mild loss. So what we do is, this is what we have started. I mean, I have been practicing right from my beginning. We call in the attender. So I first check the hearing with a whisper and even the, all the kinds of, my audiologist is there. He calls the patient, and now I'm going to switch on the volume. It's there, the volume is there, right? Okay. Now that's the gel foam being placed. So in fact, when Shia was asked the question, do you ask the patients to travel? He said, you can even ask the patient to bungee dive after a month. That's, I remember his answer even now. So all these are ringing in my ears. So still, I feel I'm so inferior to Professor Shia's technique. It's so beautiful when he does it. Okay, now let us see. Now, what happens is that once I do that, this is what happens in my theater. Something very funny, but very, very, very useful medico-legally. So it's now 27 minutes, 28 minutes now. You can see that It's not the time again, but generally my timing for stapedectomy is around.
உங்க பேர் என்ன?
So this is what happens. The patient's attender comes in. So, and then what I do is I test it in front of them. Sound wait up. Sound, make sound. Now you see.
You ask them to call the name.
நீங்க அட்டெண்டருக்கு என்ன வேணும்? இந்த பேஷண்ட்க்கு என்ன வேணும்? பேஷண்டோட
If you know Tamil, you can understand.
இப்போ நான் பேஷண்ட்ட பேச போறேன். அவர் கேக்குதா இல்லையான்றதை நீங்க பாருங்க. சரியா? சார் உங்க பேர் என்ன?
சரவணகுமார் சார்.
நல்லா நீங்க கத்திக்க சொல்லுங்க.
ஆர் சரவணகுமார்.
சரி, உங்க அப்பா பேர் என்ன?
So I start with the conversation, which is around 40 decibels, and then I go to a whisper is around 25, and then I go to a very small whisper, which is around 10-15. And you can see that I test one by one, and then I record that.
உங்க அம்மா பேரு?
புவனேஸ்வரி.
இப்போ நான் மெதுவா பேசுவேன், அதை நீங்க
Then
சொல்லுங்க.
I
சரியா?
go for the lower decibel.
சரவணகுமார்.
I go for the sharp whisper.
நான் சொல்ற நம்பரை திருப்பி சொல்லுங்க.
It's a more of a legal valid point.
Yes, this is completely medical legal. So what happens is that immediately after the patient goes out, we have a consent form again. We have a complete consent form.
சூப்பரா கேக்குதா?
கேக்குது சார்.
Now you see what
சூப்பரா கேக்குதா?
I go along with the patient after closure, and then what happens is that she has to sign saying that the patient was hearing very well on the table.
On the table.
On the table. So this is a complete consent, both verbal and video consent. So
சூப்பரா கேக்குதாம்மா?
கேக்குதுங்க சார்.
எப்படி கேக்குது சொல்லுங்க.
நல்லாவே கேக்குது.
சந்தோஷமா?
ஓகே.
Thank you.
so this happens in every
சொல்லுங்கம்மா என்ன பிரச்சனைன்னு சொல்லுங்க.
So this is after
கொஞ்சம்
when she's going to sign the consent form, she's being interviewed now.
ஸ்கூல்ல படிச்சிட்டு இருந்தான். ஹாஸ்டல்ல இருந்ததுனால நாங்க கொஞ்சம் கண்டுக்காம விட்டுட்டோம். சில சமயங்களில் கூப்பிடும்போது ரெஸ்பான்ஸ் பண்ணும்போது கேட்டோம், ஆனா அவன் எதுவுமே சொல்லவே இல்லை. ஆனா திரும்ப கேட்டு ஒரு நாள் மிரட்டி கேட்க விட்டு தான் ஆமா எனக்கு காது கேட்கல அப்படின்றத சொன்னான். அதுக்கப்புறம் இங்க வந்தோம், எங்களால திரும்பி வந்து இங்க பார்க்க முடியல. எங்க மாமனார் வேற இறந்துட்டாரு, அதனால அப்படியே கொரோனா வந்துருச்சு, விட்டுட்டோம். அதனால சரி இப்ப இதுக்கு மேலேயும் நம்ம வச்சிருக்க கூடாது அப்படின்னு சொல்லிட்டு தான் அன்னைக்கு கிளம்பி வந்தோம். மறுநாளே போய் அட்மிஷன் போடுங்க அப்படின்னாரு எங்க வீட்டுக்காரரு. அதனால அப்புறம் அட்மிஷன் போட்டு ஆப்ரேஷன்.
இப்போ எப்படி இருக்கு காது கேக்குது?
காது நல்லா கேக்குதுங்க சார்.
Okay, so I finished the video by saying that this is the main advantage. Oh, where's my stop share, man? Oh, how do I stop share, man? No, I've already stopped share. No, have I stopped share? Here, stop. Okay, can you see me, my dear friends? So this I feel is the most important advantage of a local
Anesthesia.
where what you do is you get a consent form signed with a video as well as with a audio, and this is absolutely foolproof. You cannot, I mean, of course your technique is most important, but then on a legal basis, I think this, to me, I have a record of all my maybe 8,000 patients.
One thing, sir. One thing, Janakiram, sir.
Yeah.
Even if they get SNLs afterwards, that also we are also responsible for that also. There's no need that once the table on the table it may be good, but afterwards if they get SNLs, then also we are responsible for that.
Yeah, I understand, but at least on the table you're
Yes,
right.
of course. You have done your job well.
At
You have done
least
your job well. At least on the table you've done your job.
50% of the river your cost, right? After that,
that's
of
fine.
course, your technique
That's
is going to
fine.
speak. But that
Yes.
50% itself, if you leave them into a
Of
trance,
course. Yes,
then
it's better than.
they might
it's
say,
better than-
they might say, no, he didn't hear after the surgery.
Yes, you're right. You're right.
The doctor said this guy will hear immediately after the surgery. He never
But
heard.
he's
He
not.
was under anesthesia.
Yes.
What do you do?
At least we are half the way. 50% better. Fine.
Yeah. So I think now the thing is open for discussion, and we are now.
Sir, I have a question.
Yeah.
See, when you curate most of the postmetal wall, suppose if you have curated more,
Yeah.
some cases,
Yeah.
do you reconstruct that area?
Yes, what we can do is, see, what has happened is that you can keep a little cartilage, or you can keep
Yes.
a perichondrium,
Yes.
and you can just
Yes.
reinforce that.
Yes.
In my series,
That's what I wanted to tell to the postgraduates.
Yes.
This is also an idea about it. That's why I asked for this question.
But honestly speaking, when you keep
Yes.
a cartilage, this is something which I want to tell you. We have seen that cartilage migrates. So
Of course.
we have seen cartilage migrating to the canal. So what I do is I make a sort of a L shot of cartilage, and I place one edge underneath and one edge
Okay.
above. So this is something very important. We're placing a cartilage there, and coming out, you will see it after 10 years, it's in the external canal. It'll migrate. So I think when you keep the cartilage, you have to make sure that one ledge of the cartilage is underneath the annulus and one ledge is, it should be like this. It should be like this. So that you don't
It will
have
not slip down.
cartilage.
It will not migrate. Professor Juvekar, sir, can we use the bone dust that you have created from that area to reconstruct this one, postmetal wall?
No, I don't think it's a great idea to use bone dust or bone patty, because, you know, if you're using bone dust or bone patty, you need support for it. You need support for
Gel
it.
foam under people. I have seen people putting some gel foam over that little bit of this.
Yeah, I don't think
bone
that
dust.
stands. But the only other thing that I have seen people using is maybe using a chisel, a gouge, and a hammer, and
Yeah, that
make
bit can be kept again.
from either the spine or some
Okay.
part of the mastoid antrum, and then keeping that and keeping some fascia over it, so you have some
Yes.
solid support.
Called so.
Point here is you need one piece of bone or one piece of cartilage. You cannot have
Not-
multiple pieces there.
Fine. Stability. will
And,
not
and
be-
another point is, whenever the long process of the incus is exposed more than 3/4 part of it, that is a sign that the patient might get a retraction sometimes in years to come, not always, sometimes. So,
Okay.
so how do you know when to reconstruct is a point of discussion at times.
Yeah, once what happened is one of a patient who has been doing very well came after some time with some hearing loss again. He was telling that I got again it's deteriorating. So when I saw that, he had an accident afterwards. About 6 months back, he had an accident and he has a gross DNS, and he started blowing the nose, and this part postmetal wall very created got into traction and it's pulling the piston.
Yes.
So these things may
Sir,
happen.
one thing I
So
want to tell you, at least I should not always say it's my experience or something like that. But what we have seen is that the retraction pockets are a problem when there is a problem with the eustachian tube. This is what we have observed.
yes, that's what
So
that's the
these
point I
guys
wanted to bring out.
who come with stapes surgery, surprisingly, even if you curate, not very much, a little, they don't develop retractions. We have seen humpty number of cases because you have a good eustachian tube function. And
won't
if you
suffer.
have a problem with the eustachian tube, then these guys are
Definitely
prone
they'll develop.
towards retraction pockets. We have found
Yes.
very few who have developed retractions. I can even name the numbers. I have recordings of that, of how many people have developed retractions over a long period. Now it's around 20 years of follow-up we have. So we
Yes.
exactly know how much to curate. All that comes with a little experience. But then what I mean to
Experience.
say is that the main point I want to convey is that people ask me, when you do skull-base surgery, do they develop atrophic rhinitis? This is something which is a commonly asked question. Atrophic rhinitis, again, is not coming to everybody. If you look at, I have cut so many turbinates, it doesn't come to everybody. It comes to some people. The same way the retraction pocket doesn't come to all the people. It comes to only few people who have a problem with the eustachian tube. This is my judgment
Yes,
of
observation.
what the problem is.
Observation. Fine.
Yeah, Dr. Prakash Munka is here, a lovely gentleman, my very close friend, my brother. And I mean, after a long time, we are meeting, and
in a
really
webinar, yeah.
love to have his opinion.
Yeah, excellent discussion, and I appreciate what Manish, Dr. Murthy, and what you have shown. Some of the things I wanted to clarify, like post-oral, I have been always doing post-oral, and I find, again, I was taught by Dr. Mahadevaya and others, Dr. Ogle, they said this is the most versatile incision, come what may, you can deal in the ear. Secondly, just one point, you said at one point, while putting the piston, you want the magnification to be low. So why it is so?
Yeah. See, when you take the piston inside, if you have a long, high magnification,
Higher magnification.
what happens is that depth perception goes off.
Okay.
Whenever you have lower magnification, depth is better. So
Okay.
that is why whenever we do even endoscopic sinus surgery, if you want to make it very big, when you do a carotid surgery, then I do it very big. When I drill on the foot plate, I want a big magnification. When I want to put the piston, I want to have depth. So the difference between depth and magnification should be properly balanced. So this is the science of optics.
So number one is the depth, and number two, you see a bigger area if it is a lower magnification in the same field. Is that correct?
Exactly. So you have a
Evaluate the
panoramic
surrounding
view.
areas.
Okay.
You will not take the piston and go somewhere else.
Right. So you can see the whole field in one area with the low magnification.
Yes.
If the magnification high, you have to keep on moving the microscope. Yeah.
Yes.
Great,
Secondly,
sir.
yeah. Second point, what you said, all the techniques are good. Whatever surgeon feels comfortable. My observation is usually 90% result everybody, any technique can give. It is the fight from 90 to 99%. So there comes the experience and use. And that's why I always want to learn everybody's technique and then do what I feel best at. And
Yes,
I
sir.
think that should be the message to all the postgraduates.
And
Postgraduates.
very importantly, I want to tell you
Absolutely.
that don't change the winning horse. If you're getting
Right.
a result with a particular technique, there is no point in changing that now and saying, no, I'm going to change tomorrow. I don't believe. If
No,
you
but
have a good-
but by observing others, you come to know about the pitfalls. Like today, you have shown how you separate the nerve from the canal itself. Chorda you separate from the canal. This is hardly shown by anybody. And permeatal, as Minis is doing, for step is 90% of the people are doing permeatal. It's a good approach. Hardly encounter any problem. But yes, post-oral, whatever problem comes across, you can deal with it. Only one more point I wanted to make, like you started cautery from the skin itself. The basic surgery says skin should be a sharp cut and it should not be cauterized because that healing becomes impaired. There is a microcoagulation of the skin vessel. So what is your take on that?
Very good question. I wanted somebody to ask it. Nobody asked it. You're
Okay.
correctly.
Your friend has asked you.
What we do at the end of the surgery, which I didn't show you, is I raw the edges of that diathermized area. So because I don't want blood, I go inside of the diathermy. When I come out, I have
I
already
want
seen
blood.
the nuclear.
You want
And
to.
I make a little, because the post-oral skin, you can sacrifice even 1/3. So I
Right.
want to make a small incision there on either side and then I suture. That's it.
Make them
I think
fresh.
that's a very good point because most of the people who have just switched off and not listened to us, they will think, okay, Dr. Janki is doing with cautery, why not I should also do it with cautery? What I always practice is incision, skin incision with a knife, then deepen, and if there is any bleeder, in the subcutaneous tissue, you can always cauterize.
You can't
So
do that in
that's
step.
what I am being used to, sir.
If you do that in step,
Yeah.
you're lost. You will have a lot of bleeding. So you should.
Because you don't want even a RBC or a drop of blood.
Yeah, exactly.
Yeah, true. Agreed.
So
Thank you very much. I have done.
Hit the nail always on the head, sir.
Maybe it is now getting old and so much experience of working with people and all that. So thank you very much. Thanks for
Thank you. So anybody can unmute themselves and talk if they want. It's been a very nice session. And anybody has got any questions, they can unmute. Harsha, are you seeing anybody? Huh? Yeah, you can unmute if you want, my dear friends. You can ask Professor Mini. See, for a type 1 foot plate, believe me, for a type 1 foot plate or even a type 2 foot plate, any approach is fine, boss. In my opinion, any approach is fine.
Which is
You
fine.
can just freak out. Type 1 तो कुछ भी नहीं है. There's nothing in that. You just have to make a small hole and just put it. But for a type 3 and a type 4, that is where your real finesse comes in. And that is where your technique, your approach, your every movement helps a lot. And if there's
Maybe-
a lot of vascularity,
Maybe post-oral approach may be better in those cases, 3 and 4.
absolutely. That's what I
It will
was
give you more space for you.
exactly.
What
That's
Professor
why-
Juvekar says. What's the take, Professor Juvekar?
Well, actually,
Can we go for the post-oral approach in case of 3 and 4?
maybe after
It
seeing
will
Dr.
give
Janakiram,
space for drilling and all. Pardon?
I said maybe after seeing Dr. Janakiram, I will. give
Yes,
it a thought.
yes, maybe.
More
Yeah.
on topic.
3 and 4.
Hello.
Don't change the thoughts.
And
Dr.
Juvekar,
Janki.
second thing, I imparted the CT before surgery for the postgraduate sake.
What? I think Dr. Ramesh Rohiwal is here. He's a very close friend from Aurangabad. Sir, would you like to unmute and
Yeah. Good evening, everybody.
Hi.
It was a namaskar. Vanakkam.
Vanakkam?
A very nice discussion by Murthy sir and Minish. Very useful discussion for postgraduates. I just wanted to add a line about the consent. Somebody was asking about the late sensory neural loss, which
Yes, I was
can
asking, in
happen in the any stapes patient in anybody's hand. For that, we have to have a separate consent for stapes surgery, in which I routinely write in a local language, that is Marathi, that I have been explained all the steps of the surgery in detail, and I have been explained about the possible complications, including facial palsy and sensory neural loss. That is the first point. Second point I write is there is a likely chance that I will have improvement in hearing, but it is possible that my hearing may go down. And third point I write, I have been explained about the choice for hearing aid, but I am ready for the surgery. This is what I've started doing routinely, because nowadays, because of this consumer forum and all, people have become
we have to be
very extra
careful.
wise, and they are, always, on toes to trouble doctor. So this is something which I routinely write a separate sheet, and I take a consent with a witness, and I sign myself also on that. So this becomes a valid consent in court of law. In case if the patient lands up in any problem, you have explained everything to the patient and you are safe.
Yes,
Absolutely.
yes, sir. It's very nice.
Fully agree, sir.
Yes.
Janakiram, sir. Actually, as Sir says, we can format one sheet of this type of adding all these things so that it can be uniform consent from patients.
Yeah, we should have.
It can be circulated.
Yes, certainly.
Very nice, sir. Thank you, sir.
Thank you,
Thank you
Dr.
very much.
Ramesh.
Thank you.
Thanks a lot for joining, and namaskar.
Namaskar. Janki, it's always pleasure to join any of your webinar, including the thing which was related to song, singing and all. It was also a wonderful thing. Thank you very much. Good night, everybody.
Right, sir.
So I think we have gone for 2 hours and 20 minutes of discussion. It's really a beautiful program without pulling it too long, because people will start scolding me. Professor Murthy and Professor Minish have a lot of work.
Not at all, sir. It's a pleasure.
Yeah, it's always a pleasure to be with you. And they are very close and dear friends, and we are readily agreed to moderate the session. Really great to have friends like that. You don't get friends like this.
But I want to ask you a question. With each webinar, you seem to be looking younger.
I know you're pulling my legs at the end of the session. It's okay.
And since the time you have become a father-in-law, the glow of the face increased.
You know what? My daughter-in-law is watching the program.
The glow has increased, so I don't know. I mean, should I get my son married? I'm thinking of it.
Very nice.
Anyway, it's such a pleasure to be here today and exchange the views. And thank you, Murthy sir, and all the dignitaries there. And
I should say thank you, sir. I have learned a lot from you today. Thank you. It was a very nice presentation, sir. Thank you very much. Thank you, Janakiram, sir, for giving the opportunity.
Thank you all.
Thank you very much.
Thank you, and wish you a very happy New Year. All of you, wish you a very happy.
Yes, thank you. Wish you the same.
And happy Pongal also. Happy Pongal.
Yes.
Yes.
Thank you, sir. Thank you. Same to you. Thank you.